distinguished guests, esteemed colleagues, and fellow lifesavers, good morning and a warm welcome to Code 2026, ready to respond, ready to save. This marks the third year we have gathered for this extraordinary emergency medicine conference, and looking out at the room today, it is clear that our collective commitment to excellence has only grown stronger. As we gather here today, we aren't just filling seats in this auditorium. We are uniting the front lines of medical care. In our line of work, time isn't measured in hours or in minutes. It is measured in heartbeats. It is measured in the critical seconds between a crisis and a recovery. The theme of this year's conference, 2026, Code 2026, Ready to Respond, Ready to Save, is not just a catchy slogan. It is the reality you live every single day. It is a promise made to every patient who wheels through the emergency department doors, every individual on the other end of an emergency call, and every community relying on our resilience. The landscape of medical emergencies is shifting rapidly. From AI-driven triage protocols to groundbreaking resuscitation techniques, the tools at our disposal are evolving faster than ever. But as technology advances, the core of our mission remains beautifully unchanged. Human beings showing up for other human beings on their worst days. Over the hours today, this conference will serve as your ultimate simulation bay. We will deconstruct high-stress case studies, explore cutting-edge protocols in trauma, cardiac, and pediatric emergencies, bridge the gap between rapid technological innovation and hands-on, real-world execution. You are the modern-day architects of survival. Whether you are a paramedic responding to a medical emergency on a fellow citizen on the pavement, a nurse at the bedside, a physician in the ER, or a researcher rewriting the guidelines, you are the reason Code Blue doesn't have to mean the end of the story. So use this time to challenge the status quo, share your hardest-won victories, and learn from one another. Let us sharpen our skills, synchronize our efforts, and ensure that when the next alarm sounds, we are more than just prepared. Ladies and gentlemen, let's officially initiate Code 2026. Thank you for your dedication, your bravery, and your relentless pursuit of saving lives. Let the conference begin. Let me now take the privilege to call upon stage our esteemed guests. Our board of directors would be joining later, but here I would like to take a moment to convey the best wishes our Honorable Chairman, Sir, Dr. Satyajit Bose, our Vice Chairman, Sir, Mr. Siddhartha Banerjee, and our Joint Managing Director, Sir, Shri Shamit Chatterjee, have sent for the grand success of this event. They have not been able to join us today due to some unavoidable commitments. It is my great honor and privilege to call upon stage our esteemed speakers who have graciously joined us today for this seminar. We are incredibly fortunate to have some illustrious group of experts who bring with them a wealth of knowledge, experience, and acumen to share. I would like to first call upon stage Dr. Debashish Das Adhikari. May I please request Mr. Ramesh Lal Sir and Mr. Maloy Bhattacharya to please come on stage to felicitate our guest speakers. Dr. Debashish Das Adhikari had his graduation from MR Medical College, Karnataka, and then post-graduation from CMC Vellore. He did his fellowship on pediatric emergency medicine from Sick Kids Hospital, Toronto, Canada. Dr. Debashish built up his career in emergency medicine department at Christian Medical College, Vellore since 1999 and holding the position physician in charge of pediatric emergency since 2009 in the same institute. Moreover, Dr. Das Adhikari is a teaching faculty for MBBS, DCH, MD Pediatrics, BSc, MSc Nursing, DNB, MD Accident and Emergency Medicine in Tamil Nadu, and was one of the most principal investigators on the pre-hospital trauma care in South India. Sir, it's an absolute honor and privilege to have you amongst us today. I would now request Dr. John Acera to join us on the stage. Dr. Acera received his medical degree from Ohio State University College of Medicine along with MD, MPH, FSCEP, FAAEM, and is a director, Global Emergency Medicine Program, North Shore University Hospital, and associate professor, emergency medicine at the Zucker School of Medicine at Northwell, New York, USA. He has been in the practice for more than 20 years. He has been the course director of MEM at the Mission Hospital, Durgapur. It's a great honor for me, Dr. Acera, to welcome you on the stage. Next, I would like to call upon stage our next eminent speaker, Dr. Deena Shah. Dr. Deena Shah Dr. Deena Shah is highly experienced medical professional specializing in emergency medical services and cardiac anesthesiology, having a proven track record as a director of EMS with expertise in developing clinical processes, disaster management protocols, and large-scale training programs across India and internationally. She is the founder director of Visionaire Emergency Care Services, providing hands-on virtual and hybrid training consultancy to develop emergency services, improve ER, critical care staffing, and transform ambulance operations. Thank you, Dr. Deena Shah, for joining us today. Requesting Dr. Tausif Thangalwadi to please come up on stage. Dr. Tausif Thangalwadi is an emergency medicine specialist and serves as a medical director and chief operating officer at Life Science. With over 20 years of experience in healthcare, he has led initiatives across hospital management, emergency medicine, pre-hospital care, clinical governance, medical education, and disaster medicine. He is recognized for combining strong clinical expertise with operational leadership and health technology innovation, helping advance patient care-centered digital healthcare delivery. Dr. Thangalwadi, thank you so much for joining us today. I would now like to invite Dr. Sanyukta Datta to be on stage with us, please. Dr. Sanyukta is MBBS postgraduate fellowship in emergency medicine, MEM, MBA, consultant in HOD, emergency medicine at Fortis Hospital, Kolkata, with almost 20 years of exemplary service in the field of emergency medicine. Committed to developing emergency medicine in eastern part of India and providing excellent emergency care and service to patients. Guest lecturer in different national and international emergency medicine conferences, examiner for Royal College of Emergency Medicine, UK for the last 7 years, faculty for Society for Emergency Medicine, India for last 10 years, experienced in a variety of emergency settings and with many different patient age ranges from pediatric to geriatric. Thank you so much, Dr. Sanyukta, for joining us today. May we now please request our CEO, sir, Mr. Pradipta Swain, to come up on stage to deliver the welcome note. Sir.
Good morning, everyone. Our respected Board of Directors, Dr. Satyajit Bose, Chairman, Mr. Tarun Bhattacharya, Managing Director, Mr. Siddharth Banerjee, Vice Chairman, and Mr. Samit Chatterjee, Joint Managing Director. Our esteemed guest faculty members, Dr. Jan Akera, Dr. Tosif Thangawadi, Dr. Dina Saha, Dr. Devasis Das Adhikari, Dr. Sanjukta Datta, distinguished delegates, healthcare professionals, and my dear colleagues. On behalf of the Mission Hospital Durgapur, it is my privilege to welcome you all to Course 2026, ready to respond, ready to save. I would like to mention that due to some exigencies, our Board of Directors could not be present here. Dr. Satyajit Bose has to travel to the Ahmedabad with some very important work, and they have asked the pardon from the entire delegates. Today, we proudly host the third edition of our Emergency Medicine Conference, a platform dedicated to sharing knowledge, fostering collaboration, and advancing excellence in emergency care. Our journey began in 2023 with re-engineering emergency medicine in the peripheries and continued in 2025 with Emergency Medicine 2. Both conferences were guided by one common purpose: to strengthen emergency care and promote best practices for the community we serve. This year's theme, Ready to Respond, Ready to Save, reflects the very essence of emergency medicine. Every second matters, every decision counts, and every successful outcome is the result of a prepared, skilled, and compassionate team. The emergency department is the front line of healthcare, where lives are saved, critical decisions are made, and hope begins. It reflects the strength of the entire healthcare system. At the Mission Hospital, we remain committed to strengthening the emergency care through continuous learning, advanced technology, and the development of skilled healthcare professionals. Course is an important part of that commitment. I extend my sincere appreciation to every emergency physician, nurse, paramedic, technician, and support staff member for your dedication and resilience. Your service truly embodies the spirit of today's theme. We are privileged to have our outstanding panel of experts with us today. I encourage all participants to engage actively, exchange ideas, and carry home valuable insights that will enhance patient care in your respective institutions. My sincere thanks also go to our faculty, delegates, partners, and the organizing committee for making this conference possible. Together, let us continue building a stronger, more responsive, and patient-centered emergency care system. I wish you all the enriching and inspiring conference. Thanking you all, and thank you the delegates and my faculty members taking all the pain from traveling from all the Delhi, Chennai, and other places, Belur. Thank you all.
Thank you so much, sir. May we please have all the dignitaries and our CEO, sir, our medical director, sir, our president HR, sir, Dr. Das, sir, to please come on stage to water the plant and inaugurate the third Emergency Medicine Conclave, Code 2026, ready to respond, ready to save. Dr. Debashish Ghosh, Dr. Aritro, Dr. Tirtho Mukherjee, Mr. Rahul Kheria,
Shanti, Shanti, Shanti. Asato ma satgamaya tamaso ma jyotirgamaya mrityorma mrutangamaya Om Shanti Shanti Shanti.
Thank you so much, honorable guests and my esteemed colleagues. We start today's sessions with a presentation given by our Managing Director, Dr. Parthopal. It is the keynote address, Saving Lives by Design, Leadership, System Evolution, and Futuristic Thinking. Dr. Pal.
Hello. So good morning, every one of you. Actually, let me clarify my stand. I am the medical director, not the managing director. And so good morning to all of you once again. And my gratitude to all the faculty members who have come from far off places to enlighten us, to empower us with the knowledge, attitude, and practices. My thanks to Dr. Debashish Das Adhikari, who was my teacher in CMC Vellore when I joined the fellowship in emergency medicine in the year 2003. And then I learned, till I remember, the words of the emergency A, B, C, D, E, right? Airway with C, spine stabilization, B is breathing with oxygen, C, circulation is IV fluid, D is dislocation, assessing the neurological status. He mugged me, he made me to mug up. Secondary survey, log rolls, so I learned. I don't know if I'm doing some mistake because now I am in totally a physician, a family physician and part of medical administration. So thank you, Madam Dr. Deena Shah from Fortis. She is a teacher of Dr. Rashid, the consultant of emergency medicine in our hospital. She is our teacher, our guide. Dr. John Akera, I can say that he is the architect of emergency medicine in our hospital. The total framework of emergency medicine, we derived for his association with us for a couple of years, around 10 to 12 years, more than that. Thank you, Dr. Toship. You have also come to our mission hospital, and thank you for coming from such a long distance, covering distance from Chennai. And Dr. Sanjukta Madam from Fortis, Calcutta, my heartiest. I can say thank you to all of you for being a part of this. The crowd is less because we work in the periphery, and in the periphery, the people will start from there by 9 o'clock. So all the vehicles are coming. We under feedback. It will be more than 200, but the initial part, I think the crowd will be a little less. It will start on with around 12 o'clock, it will start increasing. And then most of the corporate hospital doctors will be having their rounds and then coming up. So this is what, and today our chairman, sir, Dr. Satyajit Bose is not with, he has gone to Dr. Ahmedabad for some delivery, some speeches. And so the keynote address, I got the opportunity to speak about the keynote address. Keynote address, I think it is, as per my interpretation, it is introduction to the topic. Now, one thing I would like to say, let us go back to the history of the emergency medicine conference, which we initiated in the Mission Hospital. So we had a group known as the core group, and which we have our CEO, sir, and our Vice President Operations, then our President Finance and HR, my medical superintendent, assistant medical superintendent. So we wanted to have a conference in the year 2023 and with a theme. And that was re-engineering the emergency medicine in the periphery to increase the knowledge, attitude, and practices. So what we did is that we had a conference, we had workshops, and subsequently in 2025, we had a second conference, and that was on pediatric emergencies. And the first conference, 2023, Dr. Suresh David, the HOD of emergency medicine at my time, was there. And 2025, Dr. Devashish was also there with us. And this subsequent years, we started on a program with what we call as the Mission Connect, in which our emergency team, along with some of the emergency physicians, moved to some of the periphery hospitals, many of the periphery hospitals, corporate hospitals, and to increase the knowledge, attitude, and practices in emergency medicine. This is the way we approached. And in the year 2026, our topic we have taken is the Codes 2026, ready to respond and ready to save. Now let us begin with a question. How many lives are saved every day before a doctor even touches the patient? How many lives are saved every day before a doctor touches the patient? Or in other words, I'd like to say, how many such patients the treatment get initiated before a physician intervenes? Our instinct says, and this is a very odd question perhaps, this is the odd thing, I also don't accept it. I will think, no, this is our instinct. Our instinct says that we believe that lives are saved by the brilliant surgeons, skilled emergency physicians, miracle drugs, cutting-edge technology. But the truth is much bigger than any one of them. We believe it is only the doctor, it is only the high-level hospital that saves the lives. But the truth is different. So let me take you to a story. Let me take you to a case scenario. A young man, a highway crash, and a system response. A bystander begins the basic life support. The control room alerts the trauma center. The ambulance arrives on the scene. ED activates the trauma team. CT scanner is ready. Blood ready for cross match. Theater informed. The neurosurgeon waits. The definitive treatment begins. Now ask yourself, who actually saved the patient? Is it the surgeon? Is it the emergency physician? Is it the nurse? Is it the ambulance driver? Is it the ED architect? Is it the biomedical engineer? Or is it the administrator? Who saved the patient? So all of them saved it. Lives are not saved by the heroes alone. It is saved by the system, and that system is framed in the form of codes, which I defined today. And perhaps one of the most powerful ideas in the modern healthcare, that saving lives by design. Next. Now going to the myth of a heroic medicine, or someone says Hollywood story or a Bollywood story. Let us say what we see. One brilliant doctor, one difficult diagnosis, one miracle operation, a tidy, happy ending. This is what is the mindset, what is the media trial, what is the trial everywhere it shows to us. We have a perception in that way. But the real story is quite different. Organized and disciplined, checklists and protocols, communication and preparation, 1,000 invisible decisions. So, one more thing I'd like to say, the design begins before the disease. Emergency medicine does not begin in the ED, it begins in the community. One, a child learns CPR in the school, roads are designed safely, ambulances are placed intelligently, disaster plans rehearsed early, and hospital run mock drills. By the time the patient reaches us, the design has already begun. So because in emergency medicine, time is not merely money, time is brain, time is myocardium, and time is kidney, and time is life. One more thing about a principle of a military leadership. People do not rise to the occasion. They fall to the level of their training. For example, if there is a cardiac arrest, no one debates, people perform because someone designed the response. And one more thing, excellence is not an accident. It is never spontaneous. It is designed, rehearsed, trained, measured, and refined. Now, one more thing, I would like to focus on the hidden architects. Healthcare may be the only profession where people you have never met can save your life. They are the invisible architects of survival. The emergency nurse. Nurse notices deterioration before anyone else. Ward attendant clears the corridor during the code blue. Housekeeping keeps the environment infection-free. Biomedical engineer ensures the defibrillator works at the 2 a.m. in the night. Security officer creates order in the middle of the chaos. And many more, blood bank, pharmacy, IT, ambulance, and front desk. Next slide. So, it is the 3 designs that saves life. We have all studied, because I am also a part of it. I have also started my management studies, and I have always taught the nursing the Donovan model. Donovan model says system plus process is the outcome. I would like to more focus system plus process plus the culture. And this is an addition, the culture. And so I have added on with this, the systems, which consists protocols, checklist, and the trauma. Pathway, the design, what happens next before anyone has to think. Preparedness, readiness built before disease, drills, marked placement, every minute saved ahead of arrival. People train teams and the hidden architects who perform because they were prepared too. This is the short picture, and this is the thing what we have been done in the ED in the peripheries. We want that in the ED in the peripheries, again, A, B, C. For example, what we need is a cervical collar. We need what we call as the oxygen. We need the chest tube. We need the pigtail catheter. We need the ECG machine. We need a needle cricotype set, a glucometer, and Thomas plane. This will add. Design itself is not reserved for the trauma center. Every peripheral unit equipped, stocked, and rehearsed is life-saving system on its own right. And this is the message what we have given in the previous emergency conference. And this is the diagram, and this is the picture of what we have tried to focus in each of the peripheries outside. Prepare the periphery, and you extend the golden hour to every doorstep. Next slide. And towards the end of mine, a hospital is defined not by its building or technology, but by what happens in the first critical minutes of an emergency. In those moments, preparedness, teamwork, and compassion make the difference. And code is how that preparedness speaks. So these are most of the codes. Now we have added on with two or three codes customized to our needs. For example, we have also started with the code CS. This happened because a placenta accreta patient enters the emergency, had a hemorrhagic head, and hypotension. And at that time, what we call the gynecologist, call the OT, call the blood bank. So instead of creating a confusion, we created a code for code CS. If the gynecologist or the obstetrician declares the code, then a 33 number is activated, and from that number, every other units are activated. And so we have introduced some of the important codes like code STEMI, code CS, and one more code, what we have, the code transport, in which the security, the GDA, the housekeeping, the reception, everyone is involved where we are transferring the patient from one unit to the another. So the code transport also we have introduced this, and this is actually giving good results in our hospital. So saving life is a shared responsibility. So my take message for that, we want Durgapur to be a city where every healthcare worker knows every code. Every hospital rehearses every response, and every citizen stands beside those who save lives. So last but not the least, I will again focus on the words saving lives by design, because, last slide. Saving lives by design. Again, I repeat, lives are not saved by the heroes alone. They are saved by the system we choose to design. And with this, I introduce the topic, Code 2026. Thank you all.
Thank you so much, Dr. Pal, for giving that overview of the sessions, what we are going to have today. Now brace yourselves for a wonderful show, a simulation on Code 2026, ready to respond, ready to save. So fasten your seatbelts and get ready to join Dr. Tirtho Mukherjee, HOD of our emergency department, to take you on a fascinating roller coaster ride. Dr. Tirtho, please honor us with your presence on the stage.
Good morning, everyone. It's my privilege to be amongst pioneers of the emergency medicine arena of Durgapur and India. It has been a pleasure to organize these sort of conferences, 3 in a row over the last few years. Having been in Durgapur, born and brought up in Durgapur, and serving the community for a long time, I think, since 1998. So a Tier 2 or Tier 3 city needs a hospital to be its rock, to be its beacon. So wherever there is chaos, there is any illness, we look up to the hospital to save us, to bring us comfort, to give us assurance, to give us care. But everywhere, this sort of endeavor, this sort of enterprise, this organization known as the hospital has its own problems, its own exigencies, emergencies. So these emergencies can happen anytime. It can be an electric fuse blowing over, creating a fire. It can be a child who walks away from his or her bed. It can be a patient, a relative, a hospital worker, even a doctor who suddenly suffers a cardiac arrest. It can be an hazardous material spill. It can be an external disaster, some bus accident, some explosion, some fire, from where patients come in. So these happen suddenly. They do not have any fixed schedule, which is why hospital prepares codes. This is nothing new. This has been there all over the world in all the major hospitals who have created codes to safeguard the machinery which helps the people. So the care matrix of the hospital, it needs a vigilance and preparedness to sustain the right resources and the proper manpower, and to assure the quality. And this is actually empowered by an enigmatic and a rational leadership to set new milestones in social accountability and patient-centric promotion of healthcare. So it is actually the system and the process which our medical director, sir, had been gracious to bring forth. So this is the codes actually keep the sanity of this juggernaut, which we actually call a hospital, and it stabilizes the community. So here, let's start the program where we have done a small video using mannequins, using volunteers to show multiple codes occurring in the mission hospital one fine day. So calling the code, it's actually a potent backup. It's a backup to continue the process, the flow. It's a summon for help. It's a safety shield. It's a promise of care that no person having a cardiac arrest will be alone anywhere in the hospital. And it's an instant redressal. An immediate action is taken. It's taken by the process. It's taken by the people serving the hospital, because they have had practice. They have had someone to design the procedure, the process, and they have the zeal and the commitment to do what is necessary. So we have already gone through this. We have code blue, which is about cardiac arrest, code red, code gray, code STEMI, and code stroke, code LSCS, code transport, which we have talked about, creating a green corridor to shift the patient, code orange. So that's what we call as ready to respond and ready to save. So again, to go to the basics, code blue, cardiac or respiratory arrest, patient suddenly the heart stops beating due to multiple reasons, or the patient stops breathing. So basic and advanced life support is started. Code red, fire or smoke, the RACE protocol, rescue, alert, contain and evacuate. Code gray, it's an external disaster or a mass casualty where multiple patients in our hospital, it is 10 or more than 10 patients arriving from the same event all of a sudden, and where our resources gets overwhelmed. So there we triage, we sort out those patients, we resuscitate, and we dispose. Whoever needs to get admitted gets admitted. Whoever needs to be sent home gets sent home with proper advice. Then code STEMI, it's an heart attack. So not a cardiac arrest. The heart doesn't stop beating, but there is a clogged artery causing severe pain, fainting, and other problems, symptoms. So you save the heart, you open the clogged artery. Code stroke, that is a cerebral thrombosis, and again a clogged artery. We try to save the brain by opening the clogged artery. Code LSCS, it's a maternal or fetal complication where we try to save the mother as soon as possible. She is the beacon, she is the light who brings a life on earth. And we try to deliver the baby. And code transport, that's an urgent patient movement we create a green corridor. Code white, some staff abuse, where we try to contain the threat and we try to diffuse the tension. And then code orange, where there is an hazardous material spill. We contain the area, we actually try to disinfect. And code pink, the missing child, where we go for a search and rescue. There are other codes too, as you have already seen. Code yellow, code purple, code black. So codes actually vary. If you go to Canada, you have a separate set of colors. If you go to America, there is a separate set. In Germany, a separate set. Or in Australia, a separate set. But here in Mission Hospital, we have, or we practice these codes in this order. So let's start the video. Sound. So that's an ordinary day in the Mission Hospital, bit cloudy. That's our emergency, our own ambulance, the team of emergency staff. Our DNB residents checking the patient. These are the hidden fighters, the hidden vigilant eyes and ears, and the care people who keep on helping the community. So a patient was having an operation, and suddenly the sky broke down.
Ja, prima hoor. Ik ga even de telefoon aan. Neem even wat bloed bij u, man.
देखो इधर तो कुछ आग जैसा लग रहा है. I think smoke from the electrical panel.
Are you serious? Stop the procedure. That have been disconnected and disconnected all electrical source.
We need evacuation urgently.
So fire has happened.
Please activate code red.
Okay, I am activating.
In the emergency department, a code is getting
Activate
activated.
code red at LBOT3. Yes, sir.
Hello. Evacuation. Code red. Annex building. Okay. Code red at annex building, 5th floor OT. Code red at annex building, 5th floor OT. Code red at annex building, 5th floor
The
OT.
team goes into action. The patient gets
Code
transferred.
transport from annex building OT to emergency
To a separate
extension.
ward.
Code transport from annex building OT to emergency extension.
Code transport. Annex OT থেকে emergency extension. Okay. Advisor please. Code transport from annex OT to emergency extension.
हेलो, कौन बोल रहा है? सुमित्रा. मैं एनेक्स बिल्डिंग ओटी से एक पेशेंट भेज रही हूँ. राइट साइडेड हार्नियोप्लास्टी के लिए प्लान था.
अभी स्पाइनल एनेस्थीसिया देने के बाद सडनली पेशेंट कोड रेड हो गया है, पेशेंट को शिफ्ट करना है।
So we have fire lifts designed for such sort of situations. So the patient gets transferred by the fire lift. This was an emergency holding area. Handover is going on. Anesthetist giving the handover to the ward doctor.
Okay, Jordan, I will do it. मैं सुमित्रा बोल रही हूँ। यहाँ पर कोड ब्लू हुआ है, कोड ब्लू इन इमरजेंसी एक्सटेंशन।
कोथा देखे? कोड ब्लू, कोथा इमरजेंसी डिपार्टमेंट।
Cardiac arrest happened.
Attention please, code blue at emergency extension. Code blue at emergency extension.
Very rare.
Sir, patient,
चैनल फ्लश करो। So heart rate returns, heartbeat returns.
This is not good. All vitals, we intubate the patient. Then we shift
But the patient is unstable.
Okay. हेलो, हाँ सर तीतू बोल रहा हूँ। वो एक कोड ब्लू हुआ था ये इमरजेंसी एक्सटेंशन पे पेशेंट पोस्ट स्पाइनल एनेस्थीसिया कार्डियक अरेस्ट हुआ था। सीपीआर हुआ, अभी जो ईसीजी है उसमें इंफिनिटबल एमआई दिखा रहा है। तो अभी तो 90/60 था, फ्लूइड बोलस दिया है, बीपी थोड़ा बड़ा है लेकिन जीसीएस अच्छा नहीं है, उसलिए इंट्यूबेट कर दिया। तो पेशेंट शिफ्ट कर रहा हूँ अभी कैथ लैब में। थैंक यू।
सुमित्रा बोल रही हूँ इमरजेंसी एक्सटेंशन से। कोड स्टेमी एट इमरजेंसी एक्सटेंशन।
हाँ, কি হচ্ছে কোড স্টেমি? কোথায় হচ্ছে? এমার্জেন্সি এক্সটেনশন। হ্যালো, কোড স্টেমি এট এমার্জেন্সি এক্সটেনশন।
हेलो, सुमित्रा बोल रही हूँ इमरजेंसी एक्सटेंशन से। कोड ट्रांसफर फ्रॉम इमरजेंसी एक्सटेंशन टू कैथ लैब।
अच्छा, कोड ट्रांसफर কোথা থেকে? emergency extension to cath lab. Okay. Attention please, code transport from emergency extension to cath lab.
So everywhere the security is ready to help us move the patient. Hand over to the cath lab staff. So this is the debriefing. Whatever has happened, we go through it to find out any flaws that had happened, which needs improvement. So that's all about a day in the hospital where emergencies happen suddenly, and we have designed the system so that the hospital responds as a whole instantaneously, leaving all sorts of their duties and rushing in to do what is necessary. Thank you. So, as we all saw, codes keep us alert. It shifts the pace. Whatever you are doing, you go forward, you accelerate your mindset, you jump into action, you do what is necessary. It maintains the flow, it diffuses the tension, the confusion. So that's why it's a sort of a Morse code, an SOS alert, which only people from the system, they can understand and they can react. It assures the care, it submits the data. So every code, it is again dissected in the later hours to understand the pros and cons and whatever difficulties we had had during the process, and what sort of preventive or actions can be taken henceforth so that such problems do not arise. And then it holds the dignity. We all know when we reach the hospital, most of the dignity is stripped bare. But whatever is remained, the hospital and the healthcare tries to hold on to that and go forward, because that is life. And we are committed to do our bit in this world. Thank you. So I would request the esteemed faculties and delegates who have been here to kindly comment on this presentation which we have done on the codes, because in Durgapur we have been having multiple issues in this hospital and scenarios that keep on happening where we try to do the essentials. But I would like to get a feedback from the different hospitals, the premier major hospitals of India, and internationally, with Dr. John from USA being here, Dr. Debashish Dashodikari from CMC Vellore, and Madam Dina Shah from the Fortis Group, and of course, Dr. Sanjukta also from the Fortis Group, Dr. Tosif, who has been a mentor to me, has taught me, has become my friend to whom I can turn to in my hours of need, and who has gone forward to be a powerful and international figure now in emergency medicine. I would request all of you to put in your comments and tell us about the codes that happen in your organization, from which we can learn something more about what more can be done to improve our infrastructure. So, Madam Dina Shah, could you tell us something more about the system? Yes,
I think it's a great way to look at what healthcare does for the community. Can I just stand there and talk to the people? No, I want to talk to people. Who uses the code in their hospitals? Anybody here? On the back? Okay, so basically the codes in my eye gets designed if you want to look at the fallacies, what went wrong and could have been done better, then only the code gets designed. I really want to applaud Mission Hospital Management and the head of department for going to the extent of transport code and First time I'm hearing that, and I think it's very useful code transport because going and navigating from emergency to various departments is a little tough. Coming to my question, when you asked me what's my experience in the code, so when I joined the hospital coming back from Australia, we didn't have a codes. So NABH assessment was about to be there, and we were told that this is the codes, you have to put it in the perspective. So all codes are done, practice done, but nobody know how we are going to get it in the practice. And I got a thought that whatever we were doing in Australia, various codes, they are already there in our system in NABH, but we as a doctor or as an administrator never realized that this can be practiced. And from there the journey begins, and up to the organ transfer we reached. So all codes were designed. Code white, what they call it, we were calling different codes, but as he said that colors are different in different areas. So I would like to give my perspective to the people that if you are in the hospital and you face any issues with any patient care or management, raise it to your immediate senior or a head of department and work on it so you can do better if you are not able to deliver your 100%. And that's where the code means process, and process means the whole team. It's like playing, bansuri or flute. If you don't play all the tunes in harmony, you can't create the tune. That's the outcome. And he already mentioned that one person cannot save the life. It has to be the whole system, up to the administrator. Then only it will reach to the patient as an outcome, and your performance will make you hero. So sometimes we forgot to sing about certain heroes, but the whole system has to come in harmony. So that's my take on codes.
Thank you, ma'am. So what you are basically saying is it's more of a communication which should come from within for any sort of problem that you encounter in the hospital. And the voice should be raised, and it should permeate to the whole system, so the system can come together and decide on a right course of action so that proper care can be delivered. So I would request Dr. John to please tell us regarding what actually goes on in New York City.
Yeah. Thank you. Thank you so much. And I do also commend you for this video that you put together. I think it's a really nice illustration of how codes work in your hospital. I think what's important about codes is to understand they have to be understood by the people that work in your institution. So we have different codes in our hospital, but most of the physicians understand what the letters and the colors mean at our hospital because they're also used at other hospitals in the New York City region, in the New York area. So you have to use things that everybody understands what they're going to be. For example, code red in our hospital is the same as code red here. We also have code fusion, which is for massive blood transfusions in our institution because everyone understands what that means. Like Dr. Dina was saying, I really do like the code transport idea. That makes a lot of sense. It's something we don't have. It's something I might steal. And bring back to New York and suggest it as an idea, because there are many times where that's the one piece of the puzzle that's missing is the transporter to bring the patient to the next stop, and it's something difficult to get. But I think one thing the most important thing is that everyone needs to understand what you're saying. So everyone, if you're going to say code blue, everyone needs to know what code blue means in your institution. So you really should pick universal terminology that people understand regardless of where they're coming from. Because many of the doctors, residents, nurses may work at other institutions in the area, so they have to understand what's being said. Yeah.
Thank you, sir. So creating an environment where everyone is kept level, at a level of understanding, same level of understanding, so that whatever goes through one people's mind should also reach the distant person standing, say, 100 meters away from you, without being told, without creating a hue and cry and creating a sort of a fear amongst the people who are collected within the hospital. So this actually needs practice. This needs dedicated decision making and then drills. So everyone knows instantly that this is what I need to do if I hear this code being announced. So I would request Dr. Debashish sir to please comment on your huge accumulated experience from CMC Vellore.
I'd like to congratulate Durgapur Mission Hospital for organizing this Code 2026 and your depictions of the videos is really maybe eye-opening for so many people. And in CMC also we have very similar codes, maybe a little bit of different name or colors, but the concepts are the same. And I really appreciate that code LSCS and code transport. Probably I'll go back and suggest in CMC also code LSCS and code transport. But thing is, the manpower of any hospitals is very volatile. And people are coming and people are going. And top of that, this code doesn't happen very frequently. It's get diluted or the protocols get deleted from the brain. So probably that's why the problem is when the active or real scenarios come, you're totally disoriented. So that's why the mock codes is very important. So regular having mock codes in a hospital where you will analyze which things went good and which was wrong, and then you see the systems, why this went wrong, and then try to correct your systems. That is very important. And so you should have a regular mock code and you should have a time frame for that. So this month or this date, in a particular month, it will be done. And nobody will be knowing that. Otherwise, people will predict and they'll be get ready. It should be suddenly mock code should be done. You must have the analysis of that. And in a real scenario, when you have a mock code, you make sure that you analyze and appreciate which was good and find out where your systems went wrong. So regular this mock code and your regular evaluations of real code will definitely improve your system and will keep on your toes.
Thank you, sir. So most enlightening, and also this is a bit of a cautionary note for every one of us that we need to be more alert and more prepared about the codes and the understanding the inadequacies by making the whole team go through it again and again will help the people.
The code in our CMC batch, CMC IDs, we put the code, one small printout with colors, and otherwise code red activated. So a new person may not know what is code red. So immediately we'll see what is the code red and what's the meaning and what. So in our small ID like things, every worker of CMC, we have around 11,000 workers. All 11,000 workers knows each and every worker of CMC. They knows the in their ID we add that small thing. So everybody knows what's the code of meaning. Other people may not know the importance of it.
So it is not that they have to wear it during
they have to come for the work and it will be there.
It's in their ID.
It will in the like a small ID where all codes are there front and back.
Okay.
Color code and
so
what's
it's
the
like
purpose.
A ready reference.
For the immediately code blue activated. They don't know what is code blue. Immediately they check what is code.
So we should start from the induction of any new employee. The codes are the lifeline, which actually are the invisible net, which keeps everything at bay, preventing chaos. So, Dr. Sanjukta, could you please come up and tell us about Kolkata? Because she has been to multiple hospitals and she knows how is it in our Tilottama, the city of joy. So, please.
Thank you, Tirtha. This was an extensive code system, I can see. Probably this is the highest number of codes I have seen in a hospital, and I am really amazed. It's an absolutely wonderful video as well. So yes, as everyone else was saying, the code transport is something we would definitely like to steal and try. And you know, other than this, what we have introduced one, which is code sepsis, where we are actually including just septic shock patients, because we know that sepsis is such a dangerous killer, and we want to you know, finish everything off within 1 hour. So we have started that recently and trying it, and another in pipeline is code trauma. So these are the two things we would like to run and see what, you know, how it goes. Other than that, yeah, most of them are kind of same, except you have a lot. But one thing I was actually wondering, as you are talking about Kolkata, Durgapur, these are closed cities, and in the Kolkata there are multiple hospitals. So it would have been better. It is not, you know, up to me or you, but maybe the hospital organizations, NABH or JCI, if they could have made the same code. Say, for example, code blue is same for all, code red is same for all. But if it would have been similar or same, then the doctors, even the junior people, I mean, other staffs, they are changing continuously. They are going to this hospital to another. So it would have been better. I mean, people will retain it more. So if we could have do something in the, you know, in the state level, city level, or, you know, country level, the same codes applied to the same things, it would be easier for people to remember. So that is one thing I believe. It, you know, if anybody can bring it up in the proper forums, I think that would be great.
It's a very intelligent, rather, observation, and helpful too, because this thing do happen, that people keep changing organization. So what is code purple in one organization might not be the same elsewhere. So this thing needs to be looked into. I hope proper forums.
Yeah, I think we should actually raise it in other conferences, and, you know, it should reach the proper people.
Thank you.
Okay.
Thank you.
Thanks.
So I would like to say here that this code transport is actually the brainchild of Dr. Parthopal, our medical director, who actually brought this up. The first time we had this sort of a delay, we have around, say, 8 lifts working in the 2 buildings, 4 each in each building, besides a small lift. So the lifts got delayed. So, and there was some issues about that. And we, the emergency department, we had a quarrel with the staff and other things. So which was actually settled down when he brought this thing up. Okay, because we have been waiting with the patient, trying to shift. The patient was on ventilation, on multiple inotropes, and it got delayed. So which is why he came up with this idea of code transport, and it was. So now I have to ask Dr. Toshib to come over, because of his huge expertise with EMS. He has been with big EMS, organization. I think you have left that now. Yeah. So he has left in June. But he has had a great thing going. He was a radio jockey too in his off time. So he is like a multifaceted guy, and we loved studying when he came to teach us. He came, I think, thrice to Durgapur, then different times. So very enigmatic personality. So I would like to request you to wrap this up and tell us more if you can, because you are more into technologies nowadays. So if you could tell us more about this code situation.
Thank you, Tirtudha. It's always a pleasure coming back to go on the stage. Okay, sorry. Yeah. So yeah, Dhonabad. I'll start from there. It's always a pleasure coming back to Durgapur. Durgapur hospitality, the way I've been welcomed with warmth, it's been amazing. And when we were focusing on the growth of emergency medicine only in tier 1 cities, Durgapur perhaps was one of the first city outside of a tier 1 city to think about emergency medicine, the concept, and establish, thanks to John and people from Long Island Jewish who came in, and all these young first practitioners of emergency medicine, Dr. Paul as well, I'm sure. Dr. Taraknath is sitting there, Tarakda is there. So all of you have been the pioneers of emergency medicine in the East, so big round of applause for you to continue holding this flag high. Thank you. So thank you for that wonderful question. It's always difficult when you have an expert panel and then you're coming in at the last to say something relevant, right? First and foremost, I want to talk about two things. We talk about the past, where we came from, and then we'll talk about the future and technology. Past was very simple. Why were the codes born? The codes were born because there were certain time-bound interventions that were needed. We talk about time is brain, time is muscle, time is life in a code blue, right? So when something is time-bound and you need to change the behavior of a large number of people, a common signal which allows everybody to understand the seriousness of the situation was needed, and the code was born. So obviously it was born with the code blue, right? Wherein a patient has no pulse and you need to respond. And if you are thinking this is only for healthcare professionals, what happens on the road when an ambulance is coming? What's a green corridor, right? It is a mass signal that we have given to a large community saying, if the ambulance siren is on, which is an audio code. It's a code that's given to you without anybody having to announce anything. You make way. So these are codes that come in. The green corridor, it's a code given to the police saying, clear the highways and make sure the ambulances are out or the organ is allowed to transfer faster. This is the past. And like all the panelists said, I'm also going to steal the code transport now. Yes, while we have applied it in the EMS system, where we say there's a disaster and we need immediate transport, we do a green corridor and we transfer, but internally inside a hospital, I don't think we've ever practiced this, and we will do. So that's about the past. But the future, where's the future? We are living in the era of wearables. We are living in the era of remote monitoring. We are living in the era of vital streaming. And of course, there is the big all-watching AI that's available, the artificial intelligence. So let's say there's an ambulance, and there's a patient who's loaded on the ambulance, and we connect the rhythm and the monitor, or even the ECG, and the ECG is transmitted to the ER. And there's AI sitting there, okay? The AI notices the STT changes, the AI alerts saying probable code stemming. The job of the ER doctor or the one who's making the decision just says yes, no. And it automatically triggers. You know, the most wonderful character, which Dr. Deena was also saying, is the gentleman who answers saying, code blue in the emergency. Okay, let me. Then tuck, 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 tuck. I says, code blue emergency. I love that character, just like her. What if AI could do that? All you have to do is press a button and AI would transfer that, okay? So technology is changing the way codes are being practiced. While I see that it's wonderful that you have such a great system where everybody is coming together, I would encourage that you explore these possibilities where once you click a button, the code is transmitted automatically to everybody who needs to, and then you can reduce the dependency on the teams that are needed. Code trauma, a code stroke, a code STEMI, everything can be brought in if you can automate certain algorithms, and it is a possibility. And we're living in that era, and hopefully during my talk on AI, I'll be able to show you a few examples as well.
So actually, I was, when we have been thinking like this, so I was thinking that someday will come where we will be having drones flying in the sky to pick up these sort of trauma cases and transferring the data to the nearby hospital or the nearby medical unit or the nearby ambulance, so that instead of people calling for help, the drone actually activates this sort of a code trauma or something, and the person is lifted from wherever the person is, because it's a real-time visual, and they know the coordinates, and they pick up the patient and they transfer. But that needs lots of funding, that's need lots of policies by the government.
I'll tell you, you don't need drones for that. That is the honest to God answer. Right now, even with the CCTV that is there, the cameras that are available, you can build in AI algorithms where they can recognize even simple things as rash driving. You have lines, green lines, which are there. on the AI-enabled camera. And if a driver is driving rash, it can alert. If there's a crash, obviously it can pick up. So you don't need drones there anymore. As long as we have a CCTV connectivity across, they can pick up and send an alert. In fact, when in my EMS system, when we were practicing for ambulance safety, we had AI-enabled cameras in the driver dashboard, driver cabin, which could look at fatigability. If the driver was dozing off or not paying attention to the road, we could get an alert. And we will say, hey, what's happening? Wake up, or take rest, stop. So this was for preventing accidents from happening. So cameras can actually do it today. You don't need to invest so much. It's not very expensive. It costs us about 1,200 rupees a month to get that done, the AI with the camera. So it is a possibility today, right now. You don't need drones.
You can put it across the hospital too, to pick up cases.
Absolutely.
In case of deserted areas where maybe a code might not be announced for quite some time because it was not recognized or picked up.
Absolutely.
Thank
it is
you.
a possibility.
Thanks a lot.
Thank you. Thank you so much.
So this was a wonderful session where we got feedbacks from multiple people who have been in more crowded, more happening and more technologically sound systems. So I feel very privileged to have been here to express my views and listen to views. And thank you all for being here, for taking time out from your busy schedule and coming over to Durgapur to help us attain a better healthcare system. Thanks a lot.
Thank you, Tirthoda, for the interesting session. And thanks to all our esteemed speakers for sharing interesting observations and enlightening us on the execution nuances of codes in different organizations and different parts of this world. Our next presentation is on re-imaging emergency care, global models and their relevance to India. Requesting Dr. John Acera to please come on stage to deliver his presentation. In the meantime, I'd also like to make an announcement. Due to paucity of time, we are not taking any tea and coffee break. So whoever wants to help themselves, the tea stall is outside. You can go out and help yourself while we continue to have the presentation. Thank you.
Which one? Yeah, I guess I'll use the laptop, sure. Oh, let's see. Will this, can I see what the slides are going to look like? Yeah, no, I could use this one, I think. I think it should be fine. I'll use this. That's fine. Okay. Thank you. Okay. Good morning, everyone. Thank you so much for having me here today. It's really nice to speak to you this morning, and it's really, I'd really like to thank the Mission Hospital for putting together this event this morning. So, a couple of disclaimers before I start. Number one, I have to understand where I'm coming from. I'm an emergency medicine physician that is trained in the United States. I've also been the course director for many years for the MEM Emergency Medicine program here at the Mission Hospital. So those are my biases coming into this talk. And I was asked to talk about global training models of emergency medicine and how they relate to specialty development here in India. So again, these are just my thoughts on how things are going, and I'm sure that a lot of these topics can be debated. But these are just what some of the things that I feel, and I welcome any sort of feedback and discussion after this presentation today too. So I think in order to understand where we're going with emergency medicine specialty development, it's important to understand where we've come from and what the past looks like. So emergency medicine really started not that long ago. We're a relatively new specialty in the house of medicine. If you look at our colleagues in internal medicine has its origins in the 1800s. So that's been a specialty that's been around for quite a long time. In the 1960s, emergency departments really lacked dedicated expertise. There were triage stations that were staffed by rotating junior residents or off-duty physicians. And if you go to many parts of the world, maybe even many parts of India, you'll notice the same thing today. In 1966, the US published the Accidental Death and Disability White Paper. And this is sort of a landmark paper that was sort of the catalyst for the development of emergency medicine as a specialty in our country, in the United States. And this exposed shocking mortality rates from trauma and a systemic gap in acute medical training. And that really was the catalyst for the birth of this specialty that we call emergency medicine we had in the United States, and it spread around the rest of the world. And really, this was really driven by a public health need. And the first residency was in 1970. Our board started in 1979. So this is, again, a relatively new specialty compared to internal medicine, compared to general surgery. We had the first emergency medicine residency opened in my home state of Ohio, the University of Cincinnati, in 1970. And then by 1979, we had the American Board of Emergency Medicine, which formalized emergency training. And I think India is sort of navigating its own version of this sort of transition today, and has been doing this for the past several years. So when you're talking about emergency medicine training, I think there's really two main paradigms of training that are happening around the world. There's the primary specialty model, which is what we have in the USA, in the UK, in Australia, and many other countries. And in that model, physicians enter a dedicated 3 to 5 year emergency medicine residency directly out of medical school. And these residents are trained specifically for how to take care of the undifferentiated patient, and this results in a distinct board certification in emergency medicine. In other parts of the world, they utilize the super specialty model, where that's many parts of Latin America, many parts of Europe, other parts of Asia use this model, where physicians complete a primary residency in something. That might be anesthesia, it might be internal medicine, it might be general surgery, and then it's followed by an add-on fellowship or subspecialty certification in emergency and critical care medicine. So, there's these are the two different pathways or generalized pathways, and this might be a bit of an oversimplification, but this is a good way, I think, of looking at emergency medicine specialty training around the world. Whereas where it's a primary specialty, residents enter emergency medicine training immediately after medical school versus as a fellowship post-training in some other type of topic. So, lessons learned from India, like the primary model, where is India in this whole model? I think India sort of sits right now in between the primary specialty model and the super specialty model. And they're sort of transitioning to this primary specialty model, seems to be what we're moving towards here in this country. So like the primary model, India aims to really moving toward a 3-year MD or DNB curriculum in emergency medicine, which is focusing on undifferentiated patient. But like the super specialty model, India must initially rely on allied specialists like our colleagues in anesthesia, surgery, internal medicine, critical care medicine, to help train our EM colleagues. So we don't have a ton of emergency medicine faculty in this country, so we're relying on other specialists to be our faculty members and our mentors in emergency medicine. And we're sort of in a transition phase, in my view, from a hybrid or a super specialty landscape into a true primary specialty model here in India. So, I think many of you who work in emergency medicine are very familiar with this timeline here in India. When did emergency medicine sort of start here in India? Not that long ago. It's a relatively new specialty. Probably from the 80s and 90s, there were the first formal steps to equip casualty officers with specific resuscitation and critical skill skills in the 1990s. In 1999, SEMI was established. The Society for Emergency Medicine India was formed, and that sort of became a crucial advocacy body for the emergency medicine physicians in this country. They're a part of IFEM, the International Federation for Emergency Medicine. In 2005, INDICM was established, another emergency medicine collaborative organization that helped grow academic partnerships in emergency medicine. From 2006 to 2008, we saw the development of MEM programs, which are the Indo-US collaborative training programs throughout the country, which were pioneering residency-style training to fill critical workforce gaps. And that was mainly started by George Washington University, and then we started running those similar types of programs, which we've been running here at the Mission Hospital since 2009. In 2009 was sort of a watershed moment for emergency medicine training here in India, and that's when the MCI recognized emergency medicine as a independent specialty, and MD programs in emergency medicine were started at that time. 2013 is when the DNB recognized emergency medicine as a specialty, and DNB emergency medicine training programs were begun at that time. And then what happens now? Today, the focus shifts from establishing the specialty to standardizing training and retaining experienced clinical talent. So we're sort of at a pathway where we're moving on to these more primary specialty models of MD and DNB training in this country. But I think there's a role here for bridging the capacity gap between not having faculty in emergency medicine to this primary specialty model. So formalized NMC and MCI training really lagged behind the immense critical demand for acute care in emergency medicine. And I think the 3-year MEM programs really function as an early specialty model for emergency medicine in this country. And we really standardized the clinical workforce while formal structures really were catching up to us. And the MEM programs in this country, I think, really led to the rapid deployment of highly trained emergency medicine physicians directly to high acuity trauma centers. And here you can see some of our previous students who are now working as trained emergency medicine specialists around the country and around the world. I think everyone here is, actually some of these folks are working in other countries too. A few years back, 2 or 3 years ago, me along with some of my colleagues at George Washington looked at what the contribution of the Indo-US training partnerships, these MEM programs, have had on the emergency physician workforce capacity here in India. And what we found is that most of the graduates of our program work clinically within emergency departments here in India. So the concern was we're just training doctors to go and work all over the world. That's really not the case. Most of the graduates from our programs are working here in country, here in India. 62.8% of them were working within India, followed by the UK, and then the Middle East, I think, came after that. But again, most of our graduates are here in India. 91% of the graduates are working in emergency departments. So they're not going off to work at ICUs or other places. Most of them are working in emergency departments. And 86.8% of the graduates are working more than 50% of their time clinically in emergency departments. The other thing we found is that our graduates are involved in teaching and our graduates are involved in research. So 66.7% of our graduates work at least a quarter of their hours teaching in emergency medicine. About a third of them spend over a fourth of their time performing research. Over half have given emergency medicine lectures around the world at the national, international, or regional level. And over half belong to a national emergency medicine organization. That might be Society for Emergency Medicine India, it could be INDIS, it could be any sort of these types of organizations. So they're participating in the specialty on a national or an international level, which is great. So, again, there's been really exceptional retention with the MEM graduates. Most of the early internationally trained graduates remain dedicated to practicing in the acute care setting and emergency departments. Most of them are working here in this country, here in India. And the other thing to note is that many of them have rapidly transitioned into department heads and clinical directors, and they've really helped shape hospital policy, particularly in the private hospital sector in this country. We've seen that at the Mission Hospital, and we've seen that at many other private hospitals throughout this country. So this has been mentioned before too. The growth of the EM workforce really facilitated the spread of protocol-driven emergency care from the major metros into the Tier 2 and Tier 3 cities, like here in Durgapur. It's because of these MEM programs, I think, that emergency medicine has grown at a place like Mission Hospital here in Durgapur. And crucially, this created a deep bench of experienced clinicians that are ready to train the next generation of emergency medicine residents. So, what happens next? These are just my thoughts of what I think the future of emergency medicine holds, or what I think some thoughts I have on what the future of emergency medicine should probably look like here in India. So, number one, I think you need to really honor veteran experience to solve what we call the supervision paradox. Right now, we have a lot of people who are interested in training in emergency medicine, but there are not a lot of quote-unquote faculty in emergency medicine, because a lot of the DNB and the MD programs only consider faculty people who have DNB and MD training credentials. But that doesn't take into consideration the many, many physicians who have spent years of experience working in emergency departments. We call the term grandfathering, where people have been working in emergency departments for years, and we should really honor that experience and recognize that these are actually qualified faculty members who we should look up to and we can actually learn from. So I think we can look towards people who have many years of experience in emergency departments. We can look towards people who have MEM training or other types of training that are not DNB or not MD training in emergency medicine. And the thousands of hours of clinical experience held by these veteran CMOs and early MEM graduates must really be formally recognized somehow. This type of tenure is the type of experience that these junior doctors and the next generation of emergency physicians really should be looking up to and aspire to be part of. Along with that, I think that we need to have some type of unified competency standard in emergency medicine. Right now, there's a bit of tribalism, with the degree tribalism in emergency medicine. We have the MEMs, we have the MDs, we have the DNBs. But is there a role for maybe a unified national board certification, like they have in the UK with the Royal College of Emergency Medicine, like we have in the United States with the American Board of Emergency Medicine? You know, if an MEM graduate, a DNB graduate, or a non-graduate who's been working for 20 years in the emergency department can all pass the same clinical exam or the clinical standard, shouldn't they all be granted the same equivalent academic privileges at that institution? It's just a thought that I'm, again, an outsider looking in, some thoughts that I have about this. Next, you know, this is a little bit outside the box, but you know, there might be a role here for some corporate and academic bridges here in India in emergency medicine and integrating the ecosystem. So it seems to me that some of the highest volume and best resourced emergency departments in this country are often in the corporate hospital sector, staffed by highly experienced MEM graduates at this point. But a lot of the MD programs are housed in medical colleges and government hospitals. So should really medical college residents do mandatory rotations in corporate emergency departments, in these more advanced departments? And should corporate hospitals be integrated into the national academic networks? There could be a role potentially there for some type of knowledge exchange or training exchange, because I think both of these institutions can learn a lot from each other, and I can think that there's a role here to advance the specialty. And finally, to retain the top clinical talent, Indian hospitals really must aggressively promote experienced ED veterans into hospital leadership. They need to understand that emergency physicians are not just shift workers, they're really operational experts, and they really have a bird's eye view of the whole healthcare system, especially from that undifferentiated patient that walks through the door of the emergency department and then eventually becomes an inpatient. I think the leadership at the Mission Hospital has a bit of an understanding of this because they have promoted a lot of graduates from the emergency medicine training program into leadership roles, and I think other hospitals can learn to do the same, and it would really empower the emergency medicine workforce here in India. And then finally, I think you need to understand what makes the Indian healthcare system unique, and you can't just copy and paste another system from another country and apply it here in India. So you can't just copy the American system or the British system or the Australian system or any other country's system. You really need to learn from what we're doing and see what will work here at part of your Indian system and will not work here in some of the Indian system. So these are just some of my thoughts on what makes the Indian healthcare system unique or different from other healthcare systems. You can really lean into this when you're designing your version of emergency medicine and emergency medicine training. First off, there are various payment models here in India, but the self-pay model seems to be a lot more dominant here than it is in other countries. In the United States, for example, the insurance payment system is the most dominant payment system by far, and self-pay is really a minority of patients. Also, within India, there are various stages of emergency medicine specialty development regionally here in the country. So emergency medicine systems here in Durgapur might be different than another tier 2 city that doesn't have the experience of an MEM program like Durgapur has had for so many years. One thing that I find very unique, as an outsider from the US, is family-assisted care here in India. We don't have that. I don't know if you realize it because you're just so used to it here in India, but the role of family in healthcare in India seems to be a lot more prominent than it is in other countries. And you can rely on family to do a lot more things for your patients that we cannot do in the United States. We really have to maybe have to rely on social workers or nurses or other allied health professionals to assist with those types of tasks. So you could really lean into the role that family members have here in India, a lot more so than we have in Western cultures. And then finally, one of the issues that you have in India is a shortage of faculty, a shortage of emergency medicine physicians. It takes a long time to train a physician and to do specialized training for physicians. One thing that you can make, it does not take as long to train a nurse or an EMT. So I think we need to rely more on initiating protocolized medicine for nurses and EMTs as a way to really rapidly expand the emergency medicine workforce here in India. So, to summarize, it seems to me that India is moving towards the specialty model of emergency medicine and away from that fellowship type model. It's important to understand how emergency medicine developed in other countries to guide the future progress in the specialty development in India. And it's also important to realize what makes the Indian healthcare system unique, and I encourage you to consider these issues as you advance emergency medicine specialty development here in India. I just want to thank all of you, especially the leadership at the Mission Hospital. It's really been a pleasure to work alongside of you, and I hope that we continue our relationship moving forward from Northwell Health and the Mission Hospital. So thank you very much, and I'll be happy to take any questions or comments on this topic.
Thank you so much, Dr. Asera, for giving us an insight into the evolution of emergency care in India vis-a-vis other countries. May I please request Dr. Devkant Pradhan to please come on stage. Dr. Sera, I'll have you once again on the stage for giving up memento. Thank you so much, Dr. Sera, and thank you so much, Dr. Pradhan. Will AI save lives or slow us down? I guess this is the most pertinent question of the decade, and we may please have Dr. Tausif Thangalwadi to join us to speak about this all-important topic.
Right, I'd send them 2 versions of the presentation, so I'll figure out which one they're going to put there. But let me ask you that question. How many of you think AI will save lives? Hands, show of hands, yes, no? Okay. How many of you think AI will harm? Tarakda is raising for both, not acceptable. Oh, there you go. Oh, fantastic, excellent. All right. Well, we already have a learned audience. Okay, but let's put a simpler question. Okay. And how many of you use AI in your daily life? Personal? And how many of you use it professionally at work? Fantastic. This is an amazing crowd. Good. And how many of you think AI will replace healthcare workers? Nurses or doctors? One hand. Only one hand. Okay, good. Fantastic. Excellent. This is the right crowd for me to talk to. Will AI save lives or slow us down, right? And I'm trying to give you a scenario right from the ambulance bay or pre-hospital care to the emergency department, to the wards, what's going right and what's going wrong. And that's where the whole discussion is about. So why do we need to discuss this? Before we get there, what can you expect? I'm going to talk a couple of scenarios from AI in pre-hospital care. I'm going to talk about AI in the emergency department. And we will also talk about where AI goes wrong. It's not all a bed of roses. There are some places where AI couldn't get it right. And what is the final verdict? We'll figure that out. Why do we need to discuss this? Minutes decide outcomes. Heart attacks, strokes, sepsis. Dr. Sanjukta talked about trauma. Everything is time bound. So if you are able to make quick decisions, you are that much better at saving more lives. And can technology help you? That's the key question. The workforce is stretched. You know, emergency departments are getting busier and busier. I have had the privilege of looking at the Mission Hospital in Durgapur, and they're very busy. And the caseload that they get is such a diverse variety, referral cases, and difficult to treat. It's like a doctor house in the house every single day, right? So that's how Durgapur's Mission Hospital's emergency department is, which is fantastic for learning for all the ED graduates. So nurse fatigue, a lot of patients sticking around in the ED, everything happens, and data is exploding. You're getting so much of data. Do you have the capability of looking at every report, every medical record, every background of the patient? Can you analyze all of that every single time in an 8-hour or sometimes a 12-hour shift and make the right decision or pick up all the right problem statements? Are you capable? That is the key question. Think of that poor radiologist who has to see hundreds of CT images and X-rays every day and make the right diagnosis. There is no room for fatigue, isn't it? Can they do it? That's the key statement, the problem statement we want to address. So let's go on. AI in pre-hospital care. So before AI, how did the world look like? A dispatcher, I'm sorry, it's going to be a few crowded slides. There's only 15 minutes, a lot there. A dispatcher is picking up the phone. They have to think. So when somebody has a problem, you're going to make a phone call. If it's a telephone operator sitting in just a telephone department of the hospital, they're not even trained to answer pre-hospital care questions. But if it is a set dispatch center, they know little bit. But how are they good enough at handling every call and saying, this patient is an emergency, this patient is not an emergency? How sure are you that they will make the right call? The data says 7 out of 10 times. That's the data. 70% of the time, they get it right. This is before AI. But when we implemented AI into the mix, where AI can recognize speech, AI can recognize the distress of the caller, AI can, take the list of symptoms and then say, this is a probable risk for, say, heart attack or stroke or one of those time-bound conditions, AI is able to help the dispatcher make the right call 9 out of 10 times. A 20% absolute increase in confidence, right? That's a 30% actually increase in confidence. So that's the first difference AI is making, dispatching the right ambulance in quick time. And this is data. All of that I'm going to discuss today is existing data. Across the study of 110,000 calls made in Denmark, AI-supported dispatch cut undetected cardiac arrest by 43%. We're living in a medical world where we look at 5 or 10% shift as amazing numbers. This is 43%, probably the best intervention after hand hygiene in infection control, right? So 43% when you put in AI into a dispatcher-assisted call of detecting the right emergency and selecting the right ambulance. This is what we used to do at Red Health. So we put in AI into the call center, and there are numbers at the bottom which is probably hidden by this TV, and I was already thinking, oh, that number is not going to be shown. The average call response time in the UK, when you call the 999 in UK, is 120 seconds. In the 911 in the US, and this is available data across, is 15 seconds. What we are able to do today in India is 2 seconds. We are able to use AI, answer these calls under 2 seconds. And that's how AI is helping us here, right in India, answer the call really fast. So that's the first scenario. Let's move on when the patient is on the way. So there is AI-enabled en route monitoring. So before that, once the ambulance doors close, the crew is on its own. You don't know what's happening in the ambulance, isn't it? It's a space where the paramedic or the doctor, they decide what's happening. Unless they give you a call and tell you something is happening, you only get the patient at the door of the emergency. Sometimes the notes are also not taken down. But with AI, what if you already knew what was coming in? The vitals are streaming continuously. You have a command center where you're able to sit and monitor these vitals. You're able to give the right instructions. Those instructions are documented. And once you know where the patient is coming, the receiving hospital can trigger your code trauma, code stroke, code STEMI ahead of time. They can. Everyone's ready. Everyone's prepped. Your transfusion protocol is initiated. The blood bank's ready. Radiologist is ready. Pharmacy is ready. Everyone's ready. Right? That's the world we want to live in. And we used to do this at Red Health, right? And I will show you an example of how we use this. We went on to become Asia's first JCI accredited medical transport system. And I hope this video plays. This is real time. This is me sitting in my office being able to see inside the ambulance, see the vitals, know the heart rate, the blood pressure, saturation level of the patient. I can make a call to the person sitting there, a video call, the doctor who's there. The person in the purple shirt is the doctor, the one with the surgical mask and cap is the paramedic, and I can tell them, this is going right, this is going wrong, can you change it? What about medico-legal documentation? I have a chat box. I can type my instruction in that chat box. It gets documented with a timestamp. So they know exactly when the intervention was done, when the alert was received, when the intervention was done. And I can enable AI on this, wherein my dashboard will alert me when there is an up and down vital set beyond a certain threshold. So that's how AI is coming in, and we can do live streaming, live monitoring of patients inside the ambulance, and we hope this will change care. And they've gotten the new version also. I brought in just because I was talking about safety. Thank you so much for putting in the new version, guys. So this is what I was talking about. We do this today. This is available today. You see those green lines on the first photo? That is driving behavior. If the driver does not stick to those lanes, I know my driver is either driving rash or they are sleepy and they are, swerving. I know that. So there is a triple alert system that goes out to people, and it's not just rash driving, it is, frequent acceleration, sudden harsh braking. We can do that. The other picture there, you see that gentleman smiling, and the green lines are looking at the mouth and the eyes. It can tell when the person is sleepy. It can tell when the person is eating something when they are driving, or if they're not wearing the uniform or not disciplined. It can tell if the driver is about to doze off. We can find this out using AI. Alert is generated. We'll call the driver and we'll say, hey, wake up. We don't want you to have an accident. Drive safely. This is AI in pre-hospital care. It can be done. Well, that was pre-hospital care, right? Fantastic. Let's go on and see if AI in the emergency department works. I was talking about the imaging. So many X-rays, so many CT scans. A lot of us, during our training as emergency consultant, we learn how to read the CT, the MRI, the X-ray, and we become good at it. But the era before, where we came from, when I was training, the very few training programs, we had to wait for the radiologist to tell us what's going wrong. And that's true in many hospitals today as well. And radiologists obviously are inundated with a lot of images, not just from ER, but ICU and the ward as well. So getting a report from the radiologist took time, and you were not able to treat the patient in time. In fact, here, stroke treatment on an average took 109 minutes. Your door to needle time was 109 minutes, okay? And only about 25% fell in the 90-minute period. Whereas now with AI, when we are able to recognize large vessel occlusions, we are now able to treat them in 75 minutes. Okay? And 2/3 of these patients are falling within the 90-minute window period. That's the massive change that's happened thanks to AI-enabled imaging, right? So 34 fewer minutes to reperfusion, and with 90 patients within 90 minutes rose from being 26.5% to 68.5%, right? So that's 1%. So that's how much of a change AI has brought. I'll introduce you to an organization that does this real time. So whatever I'm saying is not the future. This is now. This is what is happening now, okay? So AI chest X-ray triage for tuberculosis, right? Before, we used to take hours for the report to come. Today, we are taking seconds. This is Cure AI. Do you know where Cure AI company was formed? Which country was Cure AI from? India. It is Mumbai-based. It's across India, across the world. WHO now recommends Cure AI for image triaging, right? Sorry, we're not moving. Okay. Yes, so that's in seconds you can get a report, and 90% sensitivity. WHO's TB screening guidelines are recommending Cure AI, and it's deployed across 2,600 sites in 67 countries, India to the world, right? And this is all coming here, right? So that's what's happening. We also talk about AI-assisted ECG interpretation. So ECG is the big bugbear. When you are in MBBS, I'm sure it has changed now, but when I was in MBBS, I always joked to my friends, my first exam, they gave me 3 different sheets and said, recognize it. And I said, and my professor had already told me normal sinus rhythm. So I went and said normal sinus rhythm, AF and VT. And he said, good. I said, wow. And then my professor said, idiot. They were all the same ECG strip. So that was my status when I was doing my MBBS and I finished it. I'm sure times are different now, but ECG recognition for doctors sometimes is not the best of our skills if you have not spent time understanding it, right? So that can create a problem, especially in STEMI. Average door to balloon time was roughly 96 minutes before. With AI recognition, 82 minutes. So there's a 14-minute reduction in recognizing the ECG, door to needle time, door to treatment time. And it did not replace a single clinical judgment call. It just made sure the ECG was recognized and sent to the right person who could make the decision. So what we call as a clinical decision support tool. So AI is a clinical decision support tool rather than a decision-making tool. And that's what we all have to understand here. AI is not doing the diagnosis. It is helping you make the diagnosis. Let's say if I wanted to find Dr. Sudeep here in this crowded room, I will have to go and look at all the rows and find where is Dr. Sudeep. But AI will shine a spotlight on all the Sudeep sitting here, and I will find the right Sudeep that I want. So that's why clinical decision support tool is what AI is all about, okay? Right. And this, again, is India to the world. Tricog Health is a company that's available in India where they capture an ECG, they take it to the cloud, AI reads it, the cardiologist confirms it. A clinical decision support tool. This happens in India under 4 minutes. ECG diagnosis under 4 minutes, okay? And look at their spread. They are linking 32 tertiary centers to 100 secondary cities. They have saved 90,000 lives via faster STEMI care. 12,000 hospitals and clinics have them. They've screened 20 million patients, and they are screening another 150 million people every single day. That's the span of AI, and this is today, and this is from India. Okay, let's move on. What about ambient scribes? The biggest pain that all of us have is documentation. See the patient, right. See the patient, right. A lot of time is spent there, and that makes life difficult. It's tiring. We get scolded by our superiors for not writing a good note, and so on, right? So AI, when you put it in, ambient AI, it listens to all your conversations, and it has become so good that it can scribe it. And it saves, on an average, 30 minutes per day per clinical care provider, which is great for us, right? And that means we have 30 minutes more time to relax, eat food, which we don't generally have time to in our hospital. So we can do that. So what was the biggest effect of this? It reduced burnout. Our tiring nature, see, when we are in healthcare and we are treating patients, we are super excited. We feel like heroes, we are treating them very well. But when we sit down to write notes, we're like, oh my God, again, so much notes to write. I don't want to take handing over of this patient. I have to write so much of introduction notes for this, history taking I have to do. I don't want to do it. And this reduced burnout because of that. The fatigue that came because of that has been reduced from 51.9% to 38.8% within 30 days of ambient scribe adoption. I'm going to give you a couple of examples, 2 real deployments that are there. Ambience Healthcare, it does it. So they did a health pilot, 70% less cognitive load, less things that you have to remember, so you can put more attention to the patient, and 100% higher job satisfaction. And healthcare documentation, 30.7% better documentation is happening, and 40% less time spent charting. Similarly, NextGen Healthcare, 2.5 hours per day saved on documentation, and sharp drop in pajama time, right? Pajama time is your handover time. You know probably better, John, what pajama time is more. In the US, it's more your, sitting down and not being by the patient and then having to write everything down, spending time with documentation instead of real patient care, okay? And 15,700 hours saved. Of course, sorry. While that is true, an independent neutral study says that at least 16 minutes per 8-hour shift are saved when you do ambience AI, where it is reading and documenting everything that you have. But it's all not hunky-dory. Where does AI slow you down? So the first example, there was something called as the epic sepsis model. In the next slide, I'll show you a little bit more about it. It was a sepsis QSOFA criteria put in across large US hospitals and deployed to identify sepsis quickly and tell the physician, this patient is in sepsis, go and take care of the patient. A tool that was always on, but was poorly calibrated. The sensitivity was super low. So what did the clinicians do? They saw a lot of false alerts. It's like the boy crying wolf every time. So they started silencing the alarms instead of looking at the patient. They said, no, I don't want to see this, right? So that was a big problem. I'll give you why. So this was 27 or 28,000 patients across 38,000 hospitalizations. Area under the curve of right recognition of the sepsis was only 0.63, abysmal. Sensitivity of only 33%. And alerts firing on 18% of all hospitalized patients, according to them, was sepsis. And clinicians needed to investigate 109 alerts to find one sepsis patient or one extra sepsis patient. Would you do that? Look at 109 alerts? So it was very, very painful, right? So what came after this was what was important, FDA clearance. So AI tools then needed FDA clearance to be deployed in a hospital. So FDA had to approve. So that's the world that we live now. If you have an AI-assisted tool that helps you do clinical decision support, the FDA has to approve before you can apply in the hospital. So that these alerts are significant, right? So that's what was important. Where we also got it wrong was bias coming into data. When we do pulse oximetry, we know that skin color makes a difference in pulse oximetry. If somebody, because it's a color, color algorithm, color-based algorithm, if somebody's dark skin, especially in African American people, I don't know what the right political term is right now, but if you see them, you found that 30%, only 1 in 3 patients picked up, hypoxemia was picked up correctly. And then if you do an AI-based algorithm, which was the first one that came in for AI in terms of recording of vitals, it's going to get all the data wrong, right? Also, famously, there was something called as IBM's Watson for oncology, right? It recommended treatments based on findings that you gave about cancer to patients, right? And it got it wrong. it flagged treatments that were not yet approved or were not legally allowed in that country. And that's where it went wrong, okay? So AI is only as good as local application. If you have data coming from one country and you apply it in another country, AI is not going to help you. You have to have local data built into the AI for it to give you the right suggestion. This is very, very important. A little bit more about the IBM, Watson for oncology. It took $4 billion to build that software, and it got such a big loss that it was sold at $1 billion. Right? So, $4 billion bet and $1 billion exit. That's where AI got it horribly wrong. Okay, and of course there was automation bias and governance gaps. How many of you use ChatGPT today? Right. Before ChatGPT, a lot of you would have been really good at writing reports, writing letters, writing email conversations. Today with or making PPTs. Today with ChatGPT, how many of you actually use your brain, right? You give it a prompt, it gives you a solution, and you put it up. Sometimes you don't even have time to check it. Sometimes what is more dangerous is that the recommendation may be wrong. The recommendation may be giving you bad data because it picked it up from somewhere which is not verified. You accept it, you put it on your presentation. Oh my God, right? So treat AI like a new drug, not like a new gadget. So would you try any drug that comes and put it on your patient? No, you will look at the evidence, you see how much success, how much failure, is it good for the patient, is it bad for the patient? You have to treat AI like that. You can't take every recommendation that AI gives and apply it. It's not going to work for you. So that's what we call as the automation bias. You have to use some level of your knowledge, your experience, and your wisdom, apply it, and see if this makes sense or not before you decide to take it and put, because you don't know where it's learned from. You have not controlled the learning of the AI software, right? It's just learned from somewhere. You cannot trust it blindly. That's the problem statement. Okay, so I think there's a bell ringing there, so I'm going to conclude. AI saves lives. When does it save lives? It saves lives when it's validated on your own patient population and not just the vendor's patient population. And this is very, very important for you. It saves lives when it's monitored after go live, not just at launch. You have to continuously monitor and see if it's giving you the right data consistently. There'll be glitches, you have to figure them out, and you have to sort them out. It augments the clinician's judgment, does not replace it. This is what I was trying to say at the beginning as well. Your judgment can get enhanced because of it. You have to identify the right Dr. Sudeep here. Is Sudeep here? I thought I saw him somewhere. But you have to identify the right Dr. Sudeep here, but not the wrong one, okay? So you have to identify it. AI can just show the number of Sudeeps that are here. And it has a named clinical owner accountable for it. So one clinical owner has to take accountability and say, it's working right, it's not working right, and I'm monitoring this regularly. So all the other clinicians can then say, yeah, he's got our backs, we can trust, we can implement this. This is very, very important. It slows us down when it's deployed without local validation or calibration. There's Sudeep. Yeah, Sudeep is walking in now. Hi, Sudeep. How are you? I've been talking about you. You've been missing with your mush. Yeah, all right. So that's the Sudeep. I found it. I didn't need AI for him. Okay, he's here, right? Okay, so it's deployed without local validation or calibration. It generates alerts that nobody trusts, so everybody ignores. So what's the point of putting a medical monitoring device when nobody's trusting the alerts, right? So that's not going to work for you. It has no governance owner or monitoring plan. Somebody has to govern it and find out if it's working right every single time. So it's like an employee of yours. It's not a human, it's a software, but it's your employee. So you have to govern how that employee works. And it's not trusted blindly, replacing judgment instead of informing it. That's when AI is going to hurt you. Don't trust AI blindly. In today's day and age, and I'm assuming the future as well, because you all haven't got clarity on where the AI is learning from. But ultimately, the truth is, AI does not replace healthcare workers. It did not remove doctors and nurses from the loop. It only extended the time that the doctors and the nurses had in the loop. Like, it gave you more time to relax, it gave you more time to spend on other patients, and less time to have to think about smaller things which the AI can think about. So that's the verdict from me. When AI is good and when AI is bad, and rightfully all my learned audience members put their hands up for saying AI is good, AI is bad. It depends on how you use it. So the future isn't AI versus clinicians. It is clinicians who use AI well versus clinicians who don't use AI well. That's the future. So let us get on the AI train, knowing fully well that we have to control it rather than letting AI control us. Thank you so much.
When it comes to AI, every organization across industries want to have a piece of this cake. Dr. Tausif gave us clarity on how to integrate this path-breaking technology into our day-to-day operations in hospitals, what to expect and what to avoid doing. Thank you so much, Dr. Tausif. May I please request Dr. Rahul Bose to come on stage to give away the memento to Dr. Tausif. Dr. Rahul. Thank you so much, Dr. Tausif. Thank you so much, Dr. Rahul Bose. Our next presentation is a journey from experience to excellence, sharing best practices from one of the largest pediatric emergency units in India, CMC Vellore. We have Dr. Debashish Das Adhikari, HOD, Pediatric Emergency Department at CMC Vellore, here today with us to take us through this journey. Sir.
I'd like to thank Durgapur Mission Hospital for this invitation to be the faculty for Codes 2026. And I'm very happy to share my 34 years journey in CMC Vellore, building the largest pediatric emergency in India. And obviously it was pre-AI era. And so obviously I'll share it. And what you said correctly, now we are so much depending on AI, and but we cannot believe it blindly. Recently, 2 weeks back, I was making a birthday flyer for my wife. I forgot to mention the name, and AI picked up a random name, and I blindly sent that to my wife. And 7 days I could not enter my home. So it was the eye-opener for me that AI, you cannot believe it. But still, I say that without AI, we cannot now survive. Okay, let's start. From experience to excellence, sharing the best practice from the largest pediatric 60-bedded emergency in CMC Vellore. And you know that pediatric emergency medicine is probably the newest subspecialty. As Sir was telling that emergency medicine, adult emergency medicine is the newest. I think the pediatric emergency just born. It's a newborn baby in the country and still in the labor room. And you know that it's mainly now available in United States, Canada, United Kingdom and Australia. But in CMC Vellore, we started 30 years back. And our hospital is 130 years old, one of the oldest hospital in the country. And our Ida Scudder, who started the hospital, with a vision that we should be excellent in education, service, and research. And 2003, when we have this building, mother and child building, we officially had a dedicated pediatric emergency in this building, and that time we started with 2 beds in pediatric emergency medicine, and then over a time, this is when we had 2 beds. This is the front area of our pediatric emergency, and then this is the resuscitation area of our emergency when we have only 2 beds. And you can see that one IV stand, and mother and babies are on chair for 24 hours, having sepsis, diarrhea, bronchitis. And unfortunately, there is no bed. And we have only 2 beds. And then next day, we will give something like that, and for the tired mother to lie down for some times, because there is no place in this hospital, no beds in the hospital. And this is our waiting area in front of the pediatric emergency, where hundreds and hundreds children are waiting there to be seen, to be admitted. And so it's obviously very overcrowded, and we don't have any place. There is no dedicated subject of pediatric emergency in India. And then it's obviously they have no other choice, because Chennai was 150 kilometers, Bangalore was 200 kilometers, almost like 400 kilometers. There is no other hospital. Parents has no place to go. They are forced to come to us. They are not happy, but they have no choice. So then 2011, we have like 15 beds. Then 2014, we increased to 21 beds. And then still our area is crowded. Still everywhere patient, and everywhere parents are on chairs, and no bed anywhere. Same thing is continuing, and same chairs with IV fluids everywhere. Parents, no place to sit, no place to admit, no place to lie down. And so that's the way our busy are. Luckily babies are small. That's why mother can hold them and sit there for 24 hours. And then admin. Repeatedly I was rubbing my chappals and going to director's office, MS office, hospital admins, and we convinced them. 2017 we got 28 beds, and 2025 we have 30 beds. And then this is our old, and this is our new. And now all sick children, they have their own beds. They have parents to have dedicated areas. And this is our old observations area. This is our new observation area. And we have dedicated areas to consult the children. And we have dedicated, this is our old area, short stay area. This is our new area, where all children has a bed to lie down, treat them. And COVID time, another problem came. Non-COVID itself, we are so crowded. COVID time, we need dedicated areas. So we have developed a separate COVID pediatric ER, and that's the me, because they said the senior most person has to intubate. So imagine me from 8 to 5 o'clock with this dress, I'll be there in the ER. So probably, God's grace, I'm alive also today. And so our statistics has now growth. It's around 30,000 sick children. So around 100 registration in our pediatric emergency per day, and we have 30 beds. So we take care around 130 to 150 children in regular days. And when there is an outbreak for pneumonia, COVID, and all those influenza, registration in pediatric emergency goes up to 200 to 250 per day. So it's a tremendous amount of hard work. So seeing the patient is fine, but you have to have not only quality, but you have to have not only quantity, you have to have a quality. So we brought benchmarking and key performance indicators. So benchmarking is a method which identify and impacting the best practice in order to improve the performance. And the key performance indicators assess the current situations, determine the root cause for the problem, set goals, expectations, and train the performance over the time. So what are the benchmarking indicators in emergency department? So for that, we modified our existing ER. We developed a dedicated triage systems, innovative techniques we used in PES and through our PM softwares, robust documentation system, dedicated fast track areas on non-urgent patients, and regular audits and indications for all the cardiac arrest in the ER, all children readmitted in 72 hours, and who are discharged against medical advice. So then mouse is not working. Right? Okay. How do you go back? Yeah. Okay. So we found that the number is very big. So you must have a dedicated triage systems. And so triage systems, what it does, you, among all the sick patients who has come to pediatric emergency, for the mothers, their child is very sick. They don't understand. There may be non-sick mother, but they are the one who will create the maximum trouble and sound in the emergency department. And the sick child who is dying, they will be in one corner. So your dedicated triage system divide the patient into resuscitation, like which is red category, observations, that is yellow category, and non-urgent, which is green categories. So over the years, we have developed a robust triage system, so priority 1 and 2 and 3. And we developed a triage assessment form. And we developed our own triage criteria, and we have checked our sensitivity and specificity over 3,000 children, and we found that it is as good as any other triage system in the world. So we developed our own triage system at CMC Vellore, and innovative techniques, what we used, our lab reducing turnover time. So we developed a suite system for our emergency where the samples goes to the lab in 30 seconds. And for pediatric emergency, you have a separate color code. So when this goes to the lab, we get the reports within 20 minutes. So that is a suite system we have reduced. Previously, it used to take 4 hours, but now our investigation time has come down to 20 minutes. And UTIs are very common. Urinary tract infections very common in children. So we have multi-sticks machines where we get the result within 45 seconds. So if that is negative, this probably it's a viral fever or any other cause. So otherwise, urine report itself is to take 6 hours in our emergency. So which has come down to now only 45 seconds. And then we have analyzers, BVG or ABG, which is readily available. Previously, it used to go to biochem department. Now within 1 minute we get. So the other few things which has bring down that waiting time from 4 to 6 hours to hardly 1 minute now. So then this is the before AI. This is one of kind of AI where at triage itself the software decide it's a malware created some kind of software which steal the data from the admission till the investigations, and it's a like AI generated, but which is done 2012, so almost 24 years back, and it's make the patients color coded automatically, red, yellow, and green, and that comes to my pager. And if this is the pager I'm carrying almost last 24 years, and if the red patient's not picked up within 8 minutes, my phone will start vibrating. And immediately I'll call them why the priority 1 patient's waiting more than 8 minutes. So this is pre-era of AI, who is created by me at the years of 2012. And so then so all patients get the color code until they leave the emergency department. Once they leave the emergency department, it's disappeared from the board. So now, as long as patients are in emergency department, it will be on the dashboard that the other patients still not seen or not been sorted out or still under observation. So even the number is very high, 160, 170, 200, but still the system will tell you that there's no way a child can be missed in our pediatric emergency. So robust documentations, because you know that nowadays medical legal things are very high. So you must document. What sir was telling, that documentation is so important. And so we do still manual, but thing is the paper gets scanned. And now the problem with the scanning paper, the patient is coming for new birth till 16 years. They might have visited 200 times in our hospital. So we are trying to generate AI where the AI immediately will scan all their last 10 years of data and will give a gist in one page. What is their diagnosis, what is the problem, why they have come, what is the current problem. So instead of going for 45 minutes previous data, what is this problem from the birth, now the AI will tell us that within one page, the gist of his last 15 years. So we have now key indicators which is must in the emergency department, like which NABH will ask you, all these documents, airway monitoring, CPR, any continuous monitoring, intubations, physical chemical restraints, chest tubes insertion, titration of the drip and blood products, course protocol, patient that goes to the OR or urgent basis. So all these documents are very important, which probably the life-saving for the patient, and nowadays it's must. NABH come to a department, they will, any of the document they will ask for, please show all these documents, and otherwise it will be a non-performance department. So the documentation is very, very important. So we have priority 1, priority 2, ICU, HDU transfer checklist. So this checklist is very, very important. Like you have a transfer codes in your hospital. So this checklist is very important. Otherwise, you will see suddenly ambu bag is missing, oxygen cylinders got over middle of the way, or a suction catheter is missing while patient vomited on the transport. So resuscitation record, whatever, any kind of resuscitation done in pediatric emergency, it must be recorded. And among the innovation technique, it's very important that our emergency comes into, we see around 140 to 186 children in our emergency. So triage is sorted out, and priority 3 children who are non-sick, they are the biggest problem in pediatric emergency, because children are stable, parents are not under pressure, they are under pressure that they have to go back to their workplace, they have taken 1 day leave, they thought that quickly they will see the child and go back. But we have our own sick children, so we cannot entertain them also, but we have to see. So what happened, we have dedicated a consultation room in pediatric emergency where we kept 2 doctors just to see non-sick children and quickly send off, because they are the biggest creator of problem in our pediatric emergency. So we track them, and so we dedicated doctors who are not the part of the resuscitation for pediatric emergency. That really helped us, because it's 50% of the children in pediatric emergency who are not sick. So, and we have a dedicated counter for the payments, dedicated counter to get the medication for emergency children. And we developed a transfer team, because we found that the small babies who are intubated, who are on ventilator, who are on high flow, who are on inotropes, that transport time of that 10 to 15 minutes when they are going to for a procedures or going for ICU or HDU, if the team is not confident enough or they don't know much of resuscitations, any small mistake, the child will die. So we developed a team who are dedicated and well-trained for HDU, ICU or procedure transfer. Means there is checklist, the third call of the unit, third call of the PICU, the senior doctor of the emergency, like that you have a checklist who can take these sick children to different places safely. So we have now around 30 monitors in our pediatric emergency. We have ventilators, ECG machines, ultrasound machines. Previously, it used to take a lot of time to get all these things to move from different areas. Now we have in-house all these machines. They are costly, but we have in emergency. And we have a 24-hour monitor. Entire different zone of the emergencies now monitor continuously by your surveillance team. And any problem has been picked up immediately. So now you need the manpower. So we have 4 faculties who has done DM pediatric emergency from AIMS. So who are our main senior faculties. We have around 21 faculties who are trained in MD pediatrics who look after, and we have junior doctors who are the medical officers around 20. We have 90 nurses for our pediatric emergency. And we have paramedics, dedicated paramedics for our pediatric emergencies. So this is the team. And then quality, QMC. So quality management cells, they look after the different kind of records for our safety of the children. So we have different audits, monthly audits, which is maintained by the QMC department, and they come and check all the audits. Then there are few indicators like how many priority 1, how many priority 2, priority 3, how many MLC, DAMA, cardiac arrest, survived. So previously to get all this data of out of 4,000 children per month, we used to spend 3-4 days. Now after starting the software, this data we get it in 1 click of 5 seconds. So our software gives us all this data, which is must and needed by the NABH. So which is automated data, so we don't have to spend any time. And we get, then next is the, after the service is the educations. So education is very important. If you don't educate, the purpose is lost. So for that, I myself, after working 14 years in adult emergency, so now I dedicated 22 years in pediatric emergency, but 22 years back, I have been trained in sick kids. I did my pediatric emergency from Canada, and this is in Toronto University. And I did my simulation and ultrasound from Cincinnati, USA. So I've been trained from US and Canada. And then teaching activities is very important. We found that the MBBS, there is no training scopes of emergency medicine. It is out of their syllabus. MCI doesn't include that training. And also MD pediatrics also, there is no postings or training for pediatric emergency. So ultimately, doctors has no knowledge much of emergency, and pediatric emergency, obviously, it's very far. So whenever they get posted in pediatric emergency, we make sure that they are the basic trainings we do for first 1 month. And then only we give the responsibility for the sick children without training. So we have in-house training, and then we do mock drill. So every week, some part of the pediatric ward, we go and conduct the mock drill, and we see that how the systems are working. We also do disaster drill. Like suddenly we'll act like some 20 children came from his school with food poisoning. So the mock drills are very important, and that will tell you how good or how strongly or what's the strength and mistakes of your department. So now we are running fellowship program, which is national and international. Throughout the Asia, the people comes for the training in pediatric emergencies. And and now we are doing pediatric emergency masterclass throughout India. We have covered almost last 9 months, we have covered 26 places in India to spread pediatric emergency masterclass. And even not only that, recently we did masterclass in Middle East also. And so the research is very important. Without research, there is no department can complete. So the beauty of that, we have 2010 onwards, this software is running. And we have data for last 15 years, so almost like 6 lakhs children. And this data can be generated with 1 click. Suppose you want to know how many children with croup treated with needed intubations. Just I'll command my software, croup with intubations, and the last 15 years, it automatically within 5 seconds will give the data. So probably I don't think that this kind of data for children available in India anywhere. And so we have almost like 150 publications, and NABH has given us the area of excellence. And in India also we got the Center of Excellence Award. Recently I happened to get the Presidential Award. And now currently I'm the chief editor for the IAP Pediatrics to make the protocol for India. And our health minister Harshavardhan came down to see what is pediatric emergency and why it's need. So he was asking me, what is this pediatric? When there is ICU is there, why do you need pediatric emergency? So I have to explain him the difference between pediatric ICU and pediatric emergency. And then we have a this is a very stressful area, so obviously we need to distress ourselves. We go for retreat, we take care our staff very well. And now we are having a pediatric block which is coming in Ranipet. It's a 600-bedded pediatric standalone super specialty hospital, and we have 30 beds bedded pediatric emergency, which is replica of sick kids of Canada. So now from this September onwards, we'll be having 60-bedded pediatric emergency, which is the largest in the India. And it is not a luxury, it's a necessary for the India now. Thank you for listening my experience. One more. No, thank you. So I was the first trauma consultant in CMC Vellore, and I continue to carry that trauma pager for 9 years in CMC Vellore. And so that time there was a lot of problem. If any patient comes, ortho will say that it's not my patient, neuro will say it's not my patient, general surgery will say you put in ICU, resuscitate, it's not my patient. Patient will be lying in emergency department, not belongs to anybody. So then CMC Vellore and 1996 started pediatric trauma consultant. When there is a dispute, the consultant will come and say this patient belongs to ortho, ortho has to admit, and nobody can question after that because it's a direct final order of the director and has to be carried by me. So like that, I was a trauma consultant for 9 years in CMC Vellore, and this is my experience how a child should be treated, because we have a ATLS program dedicated for adult, and only one chapter is written there for pediatric trauma. But I'll try to make it as simple as possible for you people to understand what is pediatric trauma. So we are not fortunate like adult, we have different subgroup. And each subgroup has their way of managing. That's very unfortunate for pediatric trauma. And we have varieties of injuries like falls, burns, motor vehicles, sports injuries, child abuse, violence, and firearms. And not only that, the childhood injuries not same like adult, there are a lot of differences. So those differences are mainly anatomical, physiological, psychological, and during resuscitation. And if you see the anatomical difference, you see that smaller body mass. Child is small, but they are also having the same organ like adult. But if one organ gets damaged, child will have multiple organ injuries. That's a problem. So you have to be extremely careful that child might be having a lung contusion or liver lacerations, but the child may have injuries the other side of the body or just above or below the organs. And they have a large surface area. Like child with a burn, when you are calculating, you cannot calculate rule of 9 because the child with 1 year, the head and neck is 18%. And the lower limb instead of 9% is 6.5. So if you don't know how to calculate the surface areas, your Parkinson's formula calculation will be more, and more fluid you give it to the child, they'll have pulmonary edema, less fluid, they'll have a renal failure. So the surface areas are different in small children. Head is very large. I said it's almost like double. So what happened? They're more prone for head injuries. They have a short neck. All of you who have done BLS, for infant, you don't check the carotid pulse, you check the brachial pulse because the neck is very short. And their maximum injuries happen C2 to C4. So when you are C-spine radiology, you are evaluating, make sure that you concentrate and see carefully C to C4. And skivora is very common. Skivora is spinal cord injury without radiological abnormalities. So child, what happened? Trauma will happen and their x-rays of the C-spine will be normal. And you might be clearing the x-rays and says his C-spine normal, but when you examine the child, you will see child is not moving his upper limb and lower limb. He developed quadriplegic. So what happened? The ligament goes inside, like a knife is cut the cord and come back. So what skivora, if you are not knowing it, you just see the x-ray and say that C-spine is normal, and later on you will get into a big medical legal problem. So skivora is very common in small children, you be careful. And if you look at the skeletal systems, which is full of cartilage, they don't have much calcium. So what happened? They don't break, they bend like a green stick. So if you're not careful seeing the x-rays, then you will miss that green stick fracture. And later on next day, child will come back in limping, and you will see that previous day doctors has missed that fracture. And another important thing that if the child says that he has a joint pain, be very, very careful, because you are not good in looking at the growth plate or the ossification center. The ossification centers will look like a fracture and growth plate will look like ossification centers. So you'll be confused. So if you have a doubt about a joint, always get the radiology help. Otherwise, if you by mistake send the child home, the growth of the bone will be stopped for rest of the life. Child will be limping for rest of the life. So you have to be extremely careful if the child following a trauma come with a joint pain. The pliability of the chest is very, very important. So what happened? The hypoxia is a big killer for small children. And if it is a lung condition for an adult to happen, there must be rib fracture. But a small child can have a very significant lung condition when there is no fracture, because the ribs are soft. They go inside, damage the lungs, and ribs come back to the normal position without fracture. So when we'll do the chest x-ray, initial chest x-ray will be looking normal, and we'll be wondering why this child is desaturating. There is no hemothorax, there is no pneumothorax. So what's the cause? So that's why in trauma, you must give high flow oxygen, irrespective of whether chest x-ray is abnormal or normal. Because if you repeat a chest x-ray after 6 hours, you will see there is a significant lung conditions. So that's why all trauma children, you must give high flow oxygen when they come to emergency department. And the abdominal traumas are so difficult to diagnose because they don't get guarding, rigidities, all these classical findings of intra-abdominal organ damage are very, very minimal for small children. Like adult, immediately you'll get a finding. You keep the hand on the abdomen, you will get the guarding and rigidity. But child doesn't have. So you may have to depend on ultrasound to look for free fluid abdomen. Then physiological difference. Physiological means A, B, C, D, E. Their airway get obstructed very quickly. So if you see the National Geographic Channel or Discovery Channel, if you see the lion and tiger, when they have to kill the buffalo, what they do? They grab the neck. And child become, the airway get compromised, such a big buffalo die instantly. That's the only way to kill the buffalo. So I don't know what codes 2026 they had in the forest and who taught them that lion and tiger to grab the neck, block the airway and kill the buffalo, correct? I don't know. There is some CME going on in the forest also. So, but as a medical profession now we are very clear that airway obstruction kill even a buffalo who is such a huge, and small child airway obstruction will kill instantly. So hypoxia, hypovolemia, hypoglycemia, hypothermia, electrolyte imbalance, acidosis, they are the major killer for children. So when a child with trauma come to emergency department, you check A, B, C, D, E, and that's a very important steps. You don't get distracted with the injuries. You first look at the physiological stability of the child. And another thing, that the manifestation of shock in children, very, very, very like adult, if you see, you always ask what's the blood pressure. But child maintain their blood pressure till they die because of that ability to have vasoconstriction and tachycardia. So those two things, they maintain their blood pressure, and once they lost the blood pressure, it's very difficult to save the child's life. So don't depend on blood pressure. So instead of that, you should look for whether they are pale, whether they are cold, whether they have tachycardia. Don't ask for blood pressure for small children. And psychological difference, you know that we are not in a good eyes for a child, because parents all the time says, if you don't eat, we will take you to the hospital and doctor or nurses will give you big injections. So we are not angels for the child, we actually are devil for the child. And when they come to the hospitals with injuries or trauma, they think, oh, now this story will fulfill and the big injection is coming to attack me now. So they'll start crying. So now you don't know why they are crying. They're upset, they have trauma, they have pain. What is the problem? You don't know. So for that, all children with trauma, you must assess the pain score. And with that pain score, you categorize. You use a age-appropriate pain score and categorize whether there belongs to mild pain, moderate pain, and severe pain. That classification will tell you what kind of pharmacological intervention you will be doing. Suppose pain score is 1 to 4, probably you will use paracetamol. Pain score is 5 to 6, you will use NSAIDs. pain score is 7 and above, you will use morphine or morphine derivatives. So if you write pain score 4 and you are giving morphine, obviously it's not necessary. And you don't understand the pain, or you didn't understand the pain score for the child. It's an unnecessary wrong treatment, and then morphine can cause respiratory depression and cardiac arrest. So you have to be extremely careful about the pain score. And if you don't address the pain score, that itself will mimic like sepsis or hypotension or shock for the child. So that addressing pain following trauma is very, very important. And next the problem come, the use appropriate resuscitation instrument and the drugs. So we medical profession, we didn't go for engineering because we don't like math. And we are very poor in calculations, correct? And if we have to remember 30, 40 formulas to remember all these equipments, it's next to impossible. So that's why emergency department, you will mostly having Broslow step. And I'm sure you people have, or PALS, small pocket handout where the things are written for the particular weight for the child, like 6 kilos weight, 10 kilos, 15 kilos. So you can use all these pocket hand notebooks to get the proper drugs or instrument, what is best for the child. So now comes to the ABCD of trauma. So it starts with primary survey, where you try to identify which will kill this child in next 1 hour. That is called golden hour. So in golden hour, you have to prevent like tension pneumothorax, massive hemothorax, intra-abdominal injuries, pelvic fractures, femur fractures, spinal cord injuries, head injuries. So these are all big, big killer and kill the child in next 1 hour. So purpose of your primary survey to identify these big killers and to prevent the death in the golden hour. And previously it is to be called as ABCD, but 2026 starts with XABCD. They found if the bleeder you ignore, within next 2 minutes the entire blood of the child can come out and kill the child. So first you have to stop the bleeder which is massively bleeding by pressure bandage. If it is arterial, to use a tourniquet. So stop the bleed, that is the first criteria. And then you start with the ABCD. And here, airway, you have to make sure that C-spine is well protected. Otherwise, you might be taking care of airway, but the neck movement will cause C-spine injuries and child become quadriplegic rest of the life. Your intention is good, but outcome is zero. So B is the breathing with oxygen. So I told you the hypoxia can happen in children with a normal X-rays also. So you have to make sure that all patients, when come to emergency department, you give high flow oxygen. Circulation with hemorrhage control. First you stop the bleed, then you give the fluid. Otherwise, all the fluids what you give, it will come out of the body. And these for disabilities, and identify whether they have a raised ICP. If you ignore the raised ICP and send the child for a CT scan, they'll cone and die in the CT room. And brain will herniate. Then the neurosurgeon will say, sorry, now nothing can be done, it's too late. So you make sure that there is, are you attending this child with a raised ICP who needs 3% saline neuroprotective intubation before you send the child for CT scan. And E for exposure, because child is lying down, you are seeing only 180 degrees, remaining half of the things also in the back. Don't ignore the back. Make sure that you have a complete exposure and evaluations. And F for flames, fluids, and Foley's catheter. You do 3 X-rays in emergency department, C-spine, chest, and pelvis. You look for fluids in the 3 areas, fluid in the abdomen, fluid in the chest, and fluid in the heart. And Foley's catheter, look for whether fluid urine output is 1 ml per kg per hour, 0.5 ml per kg per hour, or 0.3 ml per kg per hour. So that will tell you how well hydrated this child and how perfectly your resuscitation is successful. Airway. So how many of you are good in whistling? Can you try to whistle here? See? And when you are whistling, what you are doing, you are making your lips narrow. So a blocked narrow airway only vibrate and produce the sound. If you see a child having noisy breathing, gurgling, or stridor, that indicates that the airway getting blocked. Noisy breathing means tongue falling back, GCS less than 8. Gargling means there will be fluid, vomitus, or blood. And stridor means airway is very critically narrow, probably you have to intubate now. So this sounds, if you see that pediatric, how the airways differ than adult, so their tongue is very big. And when the GCS is less than 8, their own tongue causes the obstruction for a child. So probably you have to use the oropharyngeal airway if the GCS less than 8, and with the oropharyngeal airway still it's not sufficient, you may have to go for a intubations. You have to be extremely careful about nasopharyngeal intubation, because if there is a cribriform plate fracture, the nasopharyngeal airway can migrate in the brain and draining the ventricle. And CT scan will see that your nasopharyngeal airway in the brain. So this is also very, very important, that sometimes while intubations will be not easy like adult, you might have to use cricoid presses while intubating the child. And the epiglottis is very big and floppy, which will be making another problem during intubation. So till 2 years, you try to intubate with a straight laryngoscope, and this is straight laryngoscope. The first picture is intubating at 2 years, and next picture is when you are intubating more than 2 years, where you go to aryepiglottic fold and intubate, and where you use curved laryngoscope. So straight laryngoscope less than 2 years, and curved laryngoscope more than 2 years. And obviously you have to use these formulas. Shortage of time, you can take a picture. The ET tube size is 4 plus age divided by 4 for the uncuffed, and for the cuffed age 4 plus age divided by 3.5 plus age divided by 4. So this is very important for a child. And as an ED physician, don't do this mistake. For adult, the airway is parallel. But a child, the airway is narrow like a funnel. So suppose your ET tube, if adult, first 2.5 centimeters or 3 centimeters of the ET tube goes inside, after that ET tube 100% will go until they have an anatomical problem. But for a child, even also it goes first 2.5 or 3 centimeters, after that there is no guarantee that tube will go farther, it may be tight. And you will see your saturation dropping 96, 94, 93, 91, 90, and you will be tempted to push it down. The ET tube will go inside, no problem. But this child will develop a tracheal stenosis because the airway is funnel shaped. And later on, this child will have a corrective surgery, he will be spending 5 lakhs rupees. The mistakes what you have done. You could have chosen, if 4 is not going, you could have chosen 3.5. But you have used the same 4 size tube, and now child whole life is now gone because he developed a tracheal stenosis because a small mistake and you forgot this anatomy. So obviously the airway, if it is blocked, it will be maintainable or non-maintainable. One of the biggest example is maintainable airway when jaw thrust, oropharyngeal airway. If not successful, you may have to use LMA for the paramedics or nurses. If a doctor knows how to intubate, you go for intubation. That is an example of definite airway. So there may be some situations like bad faciomaxillary, Laffoot fractures, where you won't be able to see the airway. Intubation will be extremely difficult. You have to use needle or surgical crico. And never, never forget C-spine while taking care of the airway. C-spine trauma, very rare in children, but getting a collar, appropriate size collar is very, very difficult. So if the child is unconscious, get the appropriate size sandbags and strap the head while transporting for X-rays or CT scan. After A is the breathing. How many of you have seen the 3 Idiots movie? Who is the hero of the 3 Idiots? Name of the hero? Yeah, 3 Idiots. Remember, there are 3 idiots also there. So they asked that hero, what is machine? And if I ask you what's the breathing, can you tell me the definition by 3 Idiots? There's nothing but oxygen go inside and carbon dioxide come outside. That is breathing. If oxygen cannot go, is a type 1 and carbon dioxide cannot come out, is a type 2 failure. That's as simple as breathing. In trauma also, the hypoxia, which is part of this breathing, is a major killer. Can kill the child in 4 to 8 minutes. And we'll never forget our MBBS learning, correct? Inspection, palpation, percussion, and auscultation. And that will help us to identify these 5 major killer, which will kill the child next 8 minutes. Tension pneumothorax, massive hemothorax, cardiac tamponade, open pneumothorax, and failed chest. So tension pneumothorax, your inspection findings, there may be some injuries on the chest. Palpation, there may be bony crepitus of subcutaneous emphysema. Percussion will be hyperresonant, and auscultation will be no air entry. Now what will do? Will you ask for a chest X-ray in ED? How many will raise your hand? How many of you will ask for chest X-ray? Very good. Not a single hand. Obviously, this is a clinical diagnosis. Your portable chest X-ray will take 20 minutes to half an hour. And a tension pneumothorax will kill the child in next 8 to 15 minutes. So obviously, it's a clinical diagnosis. You have to put a needle, convert your tension pneumothorax to a simple pneumothorax. Then you have a 20 to 30 minutes time to put a chest tube. Massive hemothorax. Massive hemothorax means the massive blood collection in the chest. And the chest that can collect 20% of the blood volume is side of the child. And if you, in adult, it is 1500 ml. You put a chest tube, 1500 ml blood came out. Now you say this adult have a massive hemothorax. For a child, it is 20%. And what's the blood volume for a child? Do you know that? Blood volume is 80 ml per kilos. So a 10 kilo child, how much blood is there in the body? Tell now. 80 ml per kilo. So how much? 800 ml. A 20 kilo child, how much blood in the body? 1600 ml. A 1 kilo newborn, how much blood in the body? 80 ml. So we have 80 ml per kilo's blood in our body. So to say is a massive hemothorax for a child, now you tell me how much blood should be there in the chest. 20% of 800, 160. If you put a chest tube for a 10 kilo child and the 160 ml blood comes out, it is called massive hemothorax for that child. And how is the treatment? Tell me what you will do. Now you diagnose child is having massive hemothorax, what you will do? Put a chest tube. How many of you raise the hand? How many put a chest tube? So, massive hemothorax, if you put a chest tube, if any blood collection which is 20% of the blood volume, they will have a cardiac arrest. So, you have to give 20 ml per kg of fluid bolus, then only you have to put a chest tube. Without giving 20 ml per kg fluid normal saline bolus, you should not put a chest tube because that will precipitate the cardiac arrest for the child. Second thing is, you put the chest tube for this child with hemothorax. In adult, if the blood is draining now 200 ml per hour for next 4 hours, it's an indication you have to call the cardiothoracic surgeon for thoracotomy. But for a child, it is 4 ml per kg per hour for next 4 hours. After putting the chest tube, if this child is draining 4 ml per kg per hour for next 4 hours, you have to call pediatric surgeon or thoracic surgeon to do a thoracotomy for this child. This is open pneumothorax. Any opening of the chest which is bigger than the 2/3 of the tracheal diameter, you are take to enter the professional path, this new opening, and the lung will collapse. And I'm sure that small centers will not have this type of facilities. This happened very common in South India because of one festival. The heroes will be running behind the bull and try to tame the bull. Have you seen that festivals in South India? Yes. So, and this bull will go to the chest, and very common. So if they come to a small center like that, what will do? You don't have facilities. You just take a plastic and put micropore in all 3 sides. And this video should move. I don't know why it's not moving. Yeah. Can you see now what happened? You put plastic and you put micropore. So now it's like a flap, like air can come out and air will not go in. So that will prevent the lung to collapse that side. So you will have around half an hour time to go to a higher centers. So make sure that your paramedics are trained this type of open pneumothorax to put a plastic and put micropore all the 3 sides. Don't transfer only with oxygen. That will cause lungs to collapse and sudden cardiac arrest in the ambulance. Next is the diaphragmatic fracture, the rupture. So it's always happened in the left side. Guess why it is like that? Because right side you have the diaphragm. So if you see a hemothorax, in the left side, don't get tempted to put a chest tube because you may not be a true hemothorax. It may be a diaphragmatic fracture. So pass a NG tube and take a chest X-ray. And if you see the NG tube tip is above the diaphragm, that means it's a diaphragmatic rupture. If the tube is below the diaphragm, it's a true hemothorax. So that's why always you pass a NG tube when you suspect a diaphragmatic rupture. So breathing, so how do you know the child breathing is affected? You have to look for 4 things. First, you look for the respiratory rate, 60, 50, 40, 30. Newborn till 2 months, if the respiratory rate is more than 60, 2 months to 1 year if it is more than 50, and 1 to 5 years if it is more than 40, and 5 to 10 years if it is more than 30, that will give you a first clue that this child breathing is affected. Next, you look for saturation, whether less than 95 or more than 95. If the saturation less than 95, that means this child breathing very significantly affected. Then you look for distress, mild, moderate, severe. Chest indrawing up to nipple called mild distress, nipple to clavicle, moderate distress, above clavicle called severe distress. So if it is mild distress, you give oxygen up to 8 liters. If it is moderate distress, you give oxygen 10 to 15 liters. If it is severe distress, you have to connect probably NIV or Optiflow, or this child has to go to immediate intervention or a specialist or a consultant to see why this problem is there immediately within 4 minutes. So your distress will tell you. Then you look for altered sensorium. The altered sensorium can be due to head injuries, can be due to hypoxia. But if it is due to hypoxia, will kill the child next 8 minutes. So always look for whether hypoxia causing the altered sensorium or a head injury causing the altered sensorium for this child. Next is A, B, and then C. I told you never look for the blood pressure for a child with trauma because blood pressures will be maintained till they die. Instead of blood pressure, you have to look for whether the child is pale, cold, and tachycardia, and the child pale, cold, tachycardia means blood loss is 20%. So this 5th centile BP, you must remember for it to activate different kind of protocol. So newborn, the blood pressure is 60. At 1 year, blood pressure is 70. 1 to 9 years, blood pressure is 70 plus 2x. And 9 to 13 years is 90, and more than 13 years, 100. So this is the 5th centile BP. For any child, for their maintenance of the vital perfusions for the body, this 5th centile BP is very, very important. So if the BP is less than 5th centiles, you are in big trouble. That means child has gone for a profound shock. So you know that in trauma, the most common cause will be the blood loss. But there can be a obstructive shock, cardiogenic shock, and it can be distributive shock. The commonest example of obstructive shock is your tension pneumothorax cardiac tamponade. Your cardiogenic shock could be myocardial contusions, and distributive shock can be your spinal cord injuries. So what happened? All the shock, there will be tachycardia. But in neurogenic shock, the child, when there is a spinal cord is damaged, they will have a bradycardia. So if you blindly give fluid everybody without understanding whether they have a tachycardia or bradycardia, your extra fluid will cause pulmonary edema, that itself will kill the child. So any trauma patient first to think whether this child has tachycardia or bradycardia with shock. That will tell you what category of shock you are attending this child with trauma. And this is the classifications. Class 1, Class 2, Class 3, and Class 4 blood loss in trauma. Class 1, the blood loss is 10%, Class 2 is 20%, Class 3 is 30%, and Class 4 is 40%. If the blood loss is there, immediately look for the source, where the bleeding, whether it is external bleeding or whether it's an internal bleeding. And if you have any chance to stop the bleed, you do that first, especially if it is an external bleed. But if it is an internal bleed, you don't have a scope to put a pressure bandage or do something. So for that, you think whether it is a class 1, where the blood loss is 10 to 20%, and you give fluid bolus, 20 ml per kg. If child is not improved, again you give 20 ml per kg. But if it is a class 2 shock, where the 20 to 30%, you will give 20 ml per kg bolus. You can repeat second time 20 ml per kg, but you must give a cross-match blood, which is 20 ml for whole blood, 10 ml per kg for the pack cells. If it is a class 3 shock where the blood loss is more than 30%, you give 2 boluses, 20 ml, 20 ml, but now you have to activate O negative blood. You don't have time. Cross match will take 40 minutes time. But here your time is less than 20 minutes. So you have to run to blood bank, talk to the blood bank doctor, help him to get the permission for O negative blood, get the blood from the blood bank, run back and transfuse the child if it is a class 3. If it is a class 4 shock, means here what happened, its child has almost 60 to 70% of the blood has been lost for the child. So your class 1 shock, your BP will be normal, class 2 shock also BP will be normal, class 3 BP will start dropping, and class 4 BP is not recordable. So if it is a class 4 shock, you cannot give 2 boluses. You will give only 1 bolus because all the blood is out of the body. If you give more fluid, body cannot run with normal saline. So you give 1 bolus of fluid and you activate massive transfusion protocol where you give packed cells, FFP and platelets 1:1:1. So if you don't activate the massive transfusion protocol, 100% you are going to lose this child in your emergency department. So that is your classifications and rough management plan in your ED. So for the hemorrhagic shock, if it is internal hemothorax, you give the fluid, put a chest tube. If it is pelvic fractures, you put a pelvic binder. If it is femur fractures, you put a Thomas splint. And you classify class 1, class 2, class 3, class 4 and manage according to them. So external hemorrhage, obviously you have to put pressure bandage. Internal hemorrhage mainly happen in the chest, abdomen and pelvis and femur. These 4 areas the internal hemorrhage. If it is chest, it will be hemothorax. If it is abdomen, you have to look for E-fast and look for the free fluid in the abdomen. That will tell you the source of bleed, whether abdomen or not. If the pelvic fracture, then you have to put a pelvic binder. If you don't put a pelvic binder, the blood will be lost very significantly retroperitoneal space, which will not even pick up by your ultrasound also. And you'll see suddenly child arrested because you have missed the pelvic fracture. If it is a femur fracture, which will be 25% of the blood loss, that is a very significant blood loss. You have to put Thomas splint, give the fluid bolus and give the blood. So you will see that some children, given the 2 fluid bolus, now the BP is more than 5th centile. They are called rapid responder. Some children you have given fluid and blood, BP came up but again started growing. They are called transient. That means you are missing something. And if they are not at all responding, probably you have to activate the massive transfusion protocol and damage control surgery immediately. So there are 3 kinds of response to your resuscitations and 3 kinds of management you plan in emergency department. The big problem is getting a line for the children. You are only allowed to 3 attempts or 90 seconds. And within 90 seconds, if you are not getting a line, please go for intraosseous. This intraosseous, you can give fluid bolus, you can give blood products, you can give antibiotics, you can give inotropes. Everything can be done. It's act like a central line. And I don't think this intraosseous needle no more will be available in India. So the company left India. And last 14 intraosseous needle I only purchased. So there is no more intraosseous needle available in India. So but you have a easy IO. Easy IO drill which cost around 22,000 and this needle cost around 8,000, but it can be used multiple times. And this drill can be used 500 times, needle can be used 5-6 times. So now easy IO is available and I'm sure all the emergency department must have this easy IO. So I told you that all patients who are not responding or whose BP is less than 5th centile or BP is not recordable at arrival in emergency department, you must activate massive transfusions protocol. Next is the abdominal trauma. So I told you that children will not have guarding rigidity and all these findings like adult. And like, so finding abdominal trauma is difficult, and if you miss the abdominal trauma, it's a graveyard for the child. So for that, you must look for the proper history and physical findings and always use the E-fast. E-fast will tell you whether there is a free fluid abdomen, free fluid chest, or in the free fluid in the cardiac chamber, pericardial effusions. So if you see that your free fluid abdomen is available, BP is more than 5th centile, you are allowed to go for CT scan. you send the child. Because pit surgery doesn't want to operate. Because the conservative management, the outcome is much better than a surgical intervention. That's why pit surgery rarely take the child with liver laceration, splenic laceration, renal injuries. They don't take for operating. This is all conservative management. But for that, they need a CT scan. They want to evaluate. But if you see a child at arrival less than 5th centile BP and your fluid bolus not responding, this child cannot go to CT. If this child goes to CT, he'll die in the CT room. This child has to go straight to the theater for damage control surgery. Otherwise, it will be a disaster for this child outcome. So, 90% of the splenic and liver injuries are conservative management. It's not surgical. Laparotomies are very rare in children, but obviously if there is a perforations, they should go for laparotomy. If the BP is less than 5th centile, they should go for laparotomy. If CT scan shows the significant injuries to the liver and spleen, it has been very badly damaged, they go for laparotomy. So now if you see a child with a knife like this on abdomen, so what will do? Take it out in ED? Obviously not. Child should go for a CT scan, you should know which of the organ it has passed through, and with entire resuscitations ready, then only the knife has to come out in the theater. If you take it out without theater, this child may lose the life. Next is after C is D. D means head injuries. So we are not the neurosurgeon and we don't know how to do a neurosurgery. But what happened? Primary head injury and secondary head injuries. Primary head injury means which done by the trauma. And secondary head injuries which done by you. Because you have not managed A, B, C, D properly. Hypoxia, hypovolemia, hypoglycemia, hypothermia, electrolyte imbalance, acidosis. If you don't manage it properly, it will cause secondary head injuries, which is very dangerous for the child. And secondary head injuries are much dangerous than the primary head injuries. So you must see whether they have a raised ICP. Raised ICP means anisocoria, bradypnea, bradycardia, hypertension, focal seizures, focal deficit. So if SO4, LR6. So if you see a raised ICP features, you must give 3% saline in the emergency department and you have to do a neuroprotective intubation before you send the child for CT scan. 90% head injuries are minor. So for that you have to use Pican's criteria. Because every 2000 CT scan you will do, one child developed brain cancer or blood cancer. So you cannot do CT scan for every child. And parents always will be forcing you, please do a CT scan, please do a CT scan, my child have a. But you don't know that unfortunate child whom you are doing a CT scan can have developed a cancer because of the side effect of the CT scan. So this Pican's criteria you download in your mobile phone, keep it in your ED. And this Pican's criteria will tell you whether high risk, intermediate risk and low risk. High risk means must do a CT scan, intermediate risk you observe, low risk means no need for neuroimaging. So management always you give 3% saline, you do a neuroprotective intubations and get a CT scan done and ask a neurosurgeon whether need any for surgery. After D is E, expose the child because they are prone. You have to look for the injuries because child is lying down, only half of the body you are seeing. There may be significant injuries in the back. They are prone for hypothermia, so you have to make sure that you keep them normothermic and prevent the modesty of the child. And adjuncts, I told you, the investigations. After primary survey is the secondary survey where you do head to toe examinations. Each and every inches of the body, each and every orifice of the body has to be examined. This is very, very important, very, very common. I request all of you to take a picture because you might have seen this child abuse in social media like 20 days back or 1 month back. One child came to ED and which was missed. They thought it's a fracture. Actually, it's a mother who tried to kill the child. So this child abuse is very common nowadays and which will mimic like a natural injuries. But so many times it won't be natural. If you see stories and injuries are not common, histories are keep on changing, injuries not according to the developmental age, there is delay seeking help, inappropriate level of concerns, multiple old and new fractures, posterior fractures, sternal fractures, spiral fracture, immersion burns, you must report to the police, you must report to the MS, you must report the incident report, whatever the system in your. And if you fail to do that, this time child may be lucky he's alive, but 50% of the time this child will be broad dead next time. Exactly what happened in the social media, you saw that child, he was broad dead in emergency department. Then the investigation will be there, and if they see you are the doctor who has missed this, you will get free food and free stay for 6 months by India government. So if you don't want that free food and free stay, which is jail, please write the incident report and keep the list in your mobile phone whether you have addressed this kind of injuries for the child. So pearls of the management of pediatric trauma, remember this anatomical difference, physiological difference, psychological difference, remember this resuscitations and shock which may not be related with the blood pressures. And proximity to the organs cause multiple injuries for a child. You have to be extremely careful. You may have to remember a few formulas. And never forget, if child trauma, in shock, you start giving 20 ml per kg. If no improvement, still he is pale, cold, tachycardic, give 20 ml per kg fluid bolus. And third time, no more fluid bolus, what you have learned in PALS. Here you give 20 ml per kg of blood, which is whole blood, or 10 ml per kg of packed cells. If after that still child is unstable, this child has to go for a damage control surgeries. So in summary, open and clear the airway, administer 100% oxygen, maintain airway patencies, examine the chest, establish venous access in 90 seconds, and rapidly transfuse 20 ml per kg of ringer lactate or normal saline. Thank you.
All the emergency department professionals present here, I'm sure, got very inspired to see how an extremely high volume pediatric emergency department can be run so efficiently through team effort, training, and systems and processes in place. And I hope all of my colleagues who manage pediatric trauma cases in ER has taken notes of the valuable lessons shared by Dr. Dasadikari. Thank you so much, sir. May I please request Dr. Shantanu Kumar Das to please come on stage and give away the memento to Dr. Dasadikari. Next, let's move from the emergency medicine experts and listen to a cardiologist. We have our senior cardiologist, senior consultant cardiology, Dr. Debar Khudhua, delivering a presentation on rhythms of survival, rapid recognition and management of life-threatening cardiac arrhythmias in the emergency department. Dr. Khudhua, sir.
Thank you for the introduction. Good afternoon, everyone. This is Dr. Debar Khudhua from the Mission Hospital, Durgapur. First of all, I would like to say thanks to the organizing committee for selecting me for this presentation, which is on the topic of life-threatening arrhythmias that you, emergency people, encounter day in and day out. So first of all, recognize the arrhythmia, then manage it as fast as possible. So the shared mission of an emergency specialist or emergency consultant and a cardiologist who is taking care of all this arrhythmia is to gain hemodynamic stability, first of all, because within a few minutes, the patient may die in front of your eyes. So be fast as possible. And the core philosophy is to treat the patient, not the monitor, not the ECG. I would like to highlight an ECG here and ask you, can you see anything? Can you decipher anything out of this ECG? Anybody can answer, or I'll have to give the answer anyway. So are all these P waves? The patient would have died had it been the P waves. So this is low voltage complex, isn't it? Now do a POCUS or an echo and see this. This is cardiac tamponade. So treat the patient fast, not the ECG. I had given a short history, which is 76-year-old male with recurrent syncope presented to ER with a BP of 70/50. So this is pericardial effusion. All you need to do is a tap, pericardial tap. That will save the life. Now, coming to the presentation of arrhythmia, the patients will come to you with all these symptoms like palpitation, it may be dyspnea, it may be dizziness, it may be chest pain, fainting or syncope, pre-syncope, and even sudden cardiac death that can happen in front of your eyes. So, and he may also be a survivor of sudden cardiac arrest. So, if we discuss life-threatening arrhythmias, so there are some tachyarrhythmias like VT, VF, TDP, AFib with pre-excitation, and AF or atrial flutter, AFib or AFL with fast ventricular rate. And there are some bradyarrhythmias like third degree AV block or Mobis type 2 AV block second degree, high grade AV blocks, sinus arrest or sixth sinus syndrome, and asystole. So coming to the tachyarrhythmias first, look at the last point, which is AFib or atrial flutter with fast ventricular response. Normally, this is not a life-threatening arrhythmia unless it gets complicated by hypotension. How can hypotension happen in the patients of AF with fast ventricular rate? These are the conditions like aortic stenosis, hypertrophic obstructive cardiomyopathy or hypertrophic cardiomyopathy, or an underlying coronary artery disease. And then patients with reduced ejection fraction presenting with heart failure. So these are the scenarios where an otherwise benign looking AF can precipitate to hypotension, shock and death. So if we classify tachyarrhythmias, there are some wide QRS tachyarrhythmias or WCT, and there are some narrow QRS tachyarrhythmias. So I'll come to that specifically to each one of this. So diagnosis, again, so this is a wide complex tachycardia, you can see from this picture, and there is a twisting baseline, isn't it? This is irregular twisting baseline with alternating QRS complex morphologies. So this is TDP or torsalis depointes. So what is the management of TDP? TDP is catastrophic. It will lead to death then and there. So you have to defibrillate the patient with 200 joule ideally. Then we have to give injection magnesium sulfate, bolus dose, which is 2 gram IV, to be given over 1 to 2 minutes. You may repeat the bolus dose or you may start an infusion to keep the magnesium level between 2 to 4 if it is possible. But that is not the job of an emergency physician. We have to deliver a shock to save the patient and give magnesium sulfate. Then if the TDP is due to bradycardia, this is important. You can see one ECG with bradycardia leading to TDP. Then we have to correct the bradycardia. That is the inciting cause of TDP. So you have to pace the patient, either a TCP or a TVP, which is transvenous pacing, at least at 90 to 100 beats per minute. So this is the gross difference of torsalis depointes and polymorphic VT. All polymorphic VTs are not torsalis depointes, but torsalis depointes is one of the polymorphic VTs. So if there is QT prolongation is there, then it is TDP. If the normal if the QT is normal, then it is polymorphic VT. An example of polymorphic VT is CPVT, which is catecholaminergic polymorphic VT. And the VTs that present to you with MI or STEMI or after successful reperfusion, it is a part of reperfusion arrhythmia, the polymorphic VT. This is VF, as you can see from this picture. The baseline is very irregular. You hardly assess a QRS complex out of it. And then there is VT and SBT. So SBT with aberrancy may mimic a VT because both are wide complex tachycardia or WCT. So there are some criteria. You don't need to remember all these things like Brugada algorithm or Vericke algorithm. You have to remember, I'll make it simple. If you look at these clues, like if there is AV dissociation, if you can make out any AV dissociation in the ECG lead, then it is VT. If the axis is extreme, like northwest axis, in between -90 to -80, then it has to be VT. The number 3 pointer is if there is precordial concordance, like all the QRS complexes are negative from V1 to V6, or all the QRS complexes are positive from V1 to V6. So these are the 3 easy pointers. These are all VT, not SVT with aberrancy. So this is AV dissociation. I can point it out. Can you see the T waves? So these are the T waves, right? And those are actually unequal. From this inequality, we can assume that there is a P sometimes on the top of the T waves, and that top of the T wave is distorted. So from this ECG, by looking at the top of T waves, we can see there is AV dissociation. So this rhythm is VT, nothing else. So then there is, if you can find out, luckily, a fusion bit or a capture bit. Capture bit means the normal sinus bit. So this is the capture bit, and fusion bit is in between a VT bit or ventricular bit and a capture bit, which is this one. So if you're lucky enough to get a fusion bit or capture bit, it proves that it's VT. So I'll make it more simple. Like if a patient of more than 60 years with a known ischemic heart disease, previous history of ACS, unstable angina, MI, comes to you with wide QRS tachycardia or WCT, it has to be VT in more than 95% cases. This is as simple as that. Then if the, and most of the WCTs coming to ER, like more than 80% are VT. So this is the most simple thing that you need to remember. But do not commit the fatal error, which is misdiagnosing VT as SVT with aberrancy and giving verapamil or adenosine, which can induce cardiogenic shock. It is not a crime, it is not harmful to diagnose VT as SVT with aberrancy. But do not give adenosine. That is the thing. Do not give verapamil. Do not give any beta blocker or calcium channel blocker, like verapamil or diltiazem. I'll tell you what happens next. So this is an interesting ECG. This is a wide complex tachycardia. Looks like VT, but it's irregular, isn't it? VT can be irregular, but rarely. So it is more likely to be an irregular wide complex tachycardia. And name me a rhythm which is irregular. AFib. So this is AFib with pre-excitation. Most of the atrial rhythm or atrial beats, like if the atrium is beating at 300 to 600, then there is 150 to 200 conduction of those atrial beats to the ventricle via the accessory pathway, which is pre-excitation. So if we can eliminate this rhythm by giving a shock or defib, then you get that rhythm, which is a normal sinus rhythm, and you can clearly see the pre-excitation. There is short PR, and there is a delta wave. Can you see the upsloping QRS complex? So this is delta wave, and this is short PR. So this is pre-excitation. If ever atrial fibrillation happens in this patient, this will look like this. And that may lead to catastrophic event like death. So what is the treatment? Immediate DC cardioversion with 150 to 200 joule. And you can give procainamide, but it is not available in our country that much. So you may try with ibutylite. Then again, it is not that much widely available. So one thing you can do is give a shock. And that will definitely, in most of the instances, abort the rhythm and make it normal sinus rhythm with pre-excitation. But do not give beta blocker. Again, I'm repeating, calcium channel blocker, digoxin, or even amiodarone, because all these agents block the AV node. Okay, so AV node is the filter in AFib. Whatever rate the atrium is having, like 300 to 600, if you block the AV node, all the rhythm will bypass the AV node and will be transmitted to ventricle via the accessory pathway. So AFib will become a VF, and that will lead to death. So do not give beta blocker or calcium channel blocker or dioxin or amiodarone if you can see a picture like this, which is AFib with pre-excitation. This is important. Now coming to this one. This is doomsday. This is ventricular flutter. The patient will die if you don't deliver a shock. How to recognize? Because there is a continuous sine wave pattern. This is not like a sine wave pattern of hyperkalemia. This is a fast, very fast sine wave pattern. No identifiable P, no QRS, no T. Rate is more than 200. So if we give verapamil inadvertently into a case of AFib with pre-excitation, what happens? The AFib will become VF through this ventricular flutter. So this in-between rhythm is ventricular flutter. You have given verapamil or diltiazem in AFib with pre-excitation. It has become VF, then it has become ventricular flutter, then it has become ventricular fibrillation. The treatment is definitely a shock, and that will lead to asystole if it is not given. So the treatment of VT or VF. So if it is a pulseless VT, if you are not getting pulse, so activate the ACLS protocol that you all know. Start CPR, defibrillate at 200 joule, resume CPR, adrenaline 1 milligram IV. You can repeat it after 3 minutes. You can give amiodarone like 150 to 300 milligram IV bolus. Then you have delivered another shock. That shock may become more effective after giving amiodarone. Then you can repeat the amiodarone again. Or if amiodarone is not available, you can give lidocaine. The bolus dose is 1 to 1.5 milligram per kg IV. And look for the H's and T's. H and T. I will come to that later. You know at least. And then VT with pulse. Like if it is unstable VT, the patient is dyspneic, the patient is having hypoxia, there is neural obtundation, then you have to deliver a shock, which is again 200 joule. If polymorphic, you can give asynchronous shock as well. Now stable VT, you are getting a pulse, you are getting a BP. So you can give amiodarone, 150 milligram IV, repeat bolus, or you can give procanamide. The ACC-HA says the procanamide should be preferred over amiodarone because of that reason, because procanamide blocks the accessory pathway as well, but amiodarone blocks actually more the AV node. So that's why procanamide is the choice, but it is not available again. So we have to give amiodarone anyway. So coming to the narrow QRS tachycardia. So this is a flowchart of narrow QRS tachycardia. So this is supraventricular tachycardia. This is AVNRT, nothing else. Regular, more than 200 beats per minute. There is no discernible P wave. So this is more likely a AVNRT. This is AVRT. You can differentiate if you get a pseudo P or pseudo R. Pseudo R in V1 and pseudo S in lead 2. Then you can say that the RP interval is more than 70. So it's AVRT. So treatment is same, whether it is AVRT or AVNRT, which is again, if the patient is hemodynamically unstable, we have to deliver a shock. If it is stable, if the patient is stable, then you can try vagal maneuver. It is not done. You can give adenosine, 6 milligram IV bolus, then and there, and you can repeat it. The next dose should be 12 milligram, and flush it properly. Use a two-way catheter and make a cubital access so that adenosine does get reached to the heart as fast as possible, because the half-life is very less. If it is not converted to normal sinus rhythm by adenosine, you can give diltiazem as well, which is again 0.25 milligram per kg, typically 15 milligram IV over 2 minutes. You can repeat the dose after 15 minutes. And you can also give metoprolol, IV preparation, 5 milligram, then you can repeat up to a maximum dose of 15 milligram. Amiodarone is of limited use in SBT. This is third line. I think my time is over. I'll come to the slide as fast as possible. This is AF with fast ventricular rate. You can make it out from here. This is again an AF with fast ventricular rate showing in the monitor. No discrete P waves are there. There are fibrillatory waves. which is diagnostic of AFib. The treatment is same. If the patient is unstable, give a shock, DCC. You may give UFH before or after the procedure, but do not waste time to deliver a shock thinking of heparin. You can give it later also. Echo to rule out structural heart disease is there or not. If the patient is stable, try to achieve a rate control by giving IV diltiazem or IV metoprolol and IV amiodarone as well. Echo to rule out structural heart disease because that will help you to administer anticoagulation later on. This is atrial flutter. You can see the sawtooth appearance. This is atrial tachycardia. This is important because this looks like more of a sinus tachycardia, but the P waves are negative. Can you see that? The P waves are negative in 2,3 AVF. So this is one P, and the other P is hidden in the QRS complex, in the QRS-T complex actually. So this is atrial tachycardia with 2:1 AV block. This is Bick's rule. I think Bick's was a Viennese cardiologist after whom it has been named, that if you cannot find a P wave, the P wave is more likely on the top of the T wave. You can see that P wave if you look it closely. So this is the P wave on the downsloping portion of the ST segment, T wave actually. So this is P wave. The P wave is falling on the top of T wave, and the another one P wave is embedded in the R. So you are not getting that P wave. So this is atrial tachycardia with 2:1 AV block. So what if you give adenosine? There is no harm in it. That will help you to diagnose actually. It will not cause a permanent solution to the patient, but you can see the flutter waves or the atrial activities if you can give adenosine. But the rhythm will recur. So these are the flutter waves, transient AV block created by adenosine. So what is the diagnosis of this ECG? You can see some good, well-morphed P waves here, but some absent P waves or variable P morphologies here. So this is a P, which is different from this P. Again, this P and the other P is very well established. So this is multifocal atrial tachycardia. You are getting P morphologies more than 3. So coming to the bradyarrhythmias. So there are 3rd degree, 2nd degree or high degree AV block, 6 sinus and asystole. So this is obviously a complete AV dissociation, which is complete heart block. But look at the QRS complex, I will come to that later. And this is again CHB with a more wide QRS escape bit. So if you are getting a narrow QRS escape, the rhythm is suprahesian or nodal, the upper one. And if you are getting a wide QRS escape, with the rhythm is ventricular, so it's infrahesian block. The importance, I'll come to that later, in the treatment protocol. See, this is a CHB and this is a TDP. This is brady-induced TDP. You can see the CHB because P waves are here, here, here. It's not complete AV dissociation. See, here is a P wave, here is a P wave. But this is brady-induced TDP. The treatment is not magnesium sulfate, by the way. The treatment is TPI, transvenous pacemaker. This is again complete heart block, but can you see the ST elevation in 2,3 AVF? So this is inferior MI with CHB. You need to call to activate the cath lab and reperfuse the RC or LCX, whatever is dominant, so that the CHB goes away. So this is again CHB. You can see P waves and QRS complexes are haphazard. And this is again a narrow QRS escape, which is suprahesian. This is again 2:1 AV block. You can see from this picture there are 2 P waves followed by a QRS complex. And this is regular. So this is again a CHB, more of a 2:1 block because PR interval is constant actually. This is not CHB, this is 2:1 AV block because PR interval is not varying. In CHB, the PR interval will vary, but it's 2:1 AV block, the PR interval will not vary, it is fixed. So this is a 6 sinus syndrome. You can see 1 P here, but no P there, isn't it? So the P wave is absent. This is junctional escape rhythm for that period. And this is a typical junctional escape rhythm. You can see the P wave if you look it closely over the top of T wave. This is the P wave, this is the P wave, this is the P wave. So the P coming after QRS. This is junctional rhythm. The treatment of bradyarrhythmia is giving atropine 1 mg bolus. It is effective in sinus or nodal junctional rhythm, but it is hazardous in infrahisian block or type 2, Mobitz type 2 block. So the treatment in those conditions, I'm coming to the suprahisian portion. If you can give isoprenaline, like there is a dose, you all know the dose, that will lead to increase in ventricular rate if it is suprahisian. But if you give isoprenaline or isoprenaline infusion to an infrahisial block, no change. It will not be helpful. So it fails to increase the ventricular rate if it is infrahisian. And how to know it is infrahisian? The QRS escape will be wider, isn't it? You can give adrenaline as well, because it helps to elevate the BP and increase the systemic vascular resistance, which is helpful or highly effective in shock patient, or dopamine. And do check for hyperkalemia. This is important. And beta blocker and calcium channel blocker toxicity as well. So this is transcutaneous pacing. Do not hesitate to start transcutaneous pacing at the rate of 60 to 80, but do check femoral pulse. I've seen many cases transcutaneous pacing is on, but there is no pulse, because it is not reaching, the energy is not reaching the myocardium. So it is a bridge to transvenous pacing. Shift the patient to the cath lab for transvenous pacing and increase the output as much as possible to get a good femoral pulse. So the diagnosis here is hyperkalemia. You can see the tall T waves, and there is no P wave actually. Again, this is hyperkalemia. This is again hyperkalemia. So these are the ECG changes of hyperkalemia. P wave becomes absent at the level of 7 or 7.4 of potassium. This is sine wave pattern. This is the last rhythm before asystole in hyperkalemia. It usually occurs in a patients of hyperkalemia with the level of more than 8.519. So treatment of hyperkalemia is IV calcium gluconate then and there. It will stabilize the rhythm, 10 ml, 10% in 10 minutes. That is the dictum. You can give insulin dextrose infusion, which is again 10 units of actrapid or fast-acting insulin in 100 ml, 25% dextrose, about 15 to 30 minutes. Omit dextrose if the RBS is more than 250. You can nebulize, but the dose is too high. It is not done. You can give bicarb only the patient's ABG shows acidosis. Otherwise, it will not help. The last resort is hemodialysis, and you can have normokalemia if you give Localma, which is a new drug, within 2 hours to 6 hours. So this is asystole. You know the ACLS protocol, high quality CPR, ADR, and look for HS and Ts, which is hypovolemia, hypoxia, hydrogen ion, that is acidosis, hypo or hyperkalemia, and hypothermia. These are the correctable causes. You need to look out for the correctable causes while managing or giving CPR in ACLS protocol. If the rhythm is shockable, give a defib shock. Then CPR, amiodarone, and again, repeat. So the take-home message is call for help. There are people you need, like nursing staffs and all, to manage the patients. You cannot do it alone. If it is tachyarrhythmia, wide complex, please deliver a shock. You don't need to diagnose it. Please deliver a shock. If the patient has a pulse and organized QRS, give a synchronized shock. If the patient, there is no pulse and no organized QRS, like we have seen the VF, asynchronous shock, look at the monitor after delivering DC cardioversion. This is important. Remember it, because you have seen, I think, in some cases while delivering shock, you are giving a synchronous shock, but it is made by the machine asynchronous, and your shock lands on the top of T wave, which is R on T, and that will degenerate, the rhythm will degenerate to VF or pulseless VT, then and there. So you have to look at a monitor after giving shock. If there is VF, give another shock, asynchronous. For Brady, give atropine, start transcutaneous pacing. This is a bridge to transvenous pacing, isolin, and inform the cath lab. And do check for hyperkalemia, get an ABG done, that will help, and do echo or focus, because you are treating the patient, not the ECG. Thank you so much.
Thank you so much, Dr. Dhua, for enlightening the audience here on how to manage cardiac arrhythmias to save precious lives. May I please have on stage Dr. Dina Shah to give away the memento to Dr. Debargodhua. Ma'am, please stay on the stage, ma'am. Dr. Dinasha, please stay. May I please request Dr. Krishnendu Goswami to come on stage to give away a memento to Dr. Dinasha. Thank you so much, Dr. Dinasha. Thank you so much, Krishnendu sir. That brings us to the end of second round, and we are about to begin the third section, which is the academic section. We start with presentation by Dr. Orghu Chaudhuri, consultant orthopedics at the Mission Hospital, Durgapur. Time is tissue. Early recognition and management of compound trauma in extremities with vascular injury. To chair this session, may I please request Dr. Krishnendu Goswami, Senior Consultant Plastic and Reconstructive Surgery at the Mission Hospital, and Dr. Ankit Rai, Consultant Orthopedics, to come on stage. The time allocated for this session is 30 minutes, including the expert inputs from our chairs. Thank you so much.
Thank you, everyone. Thank you, my panelists. Thank you, ma'am, for the warm introduction. The topic of discussion is time is tissue, the early recognition, the signs and symptoms, the management of compound extremity trauma with vascular injury. So going forward, the learning objectives will be the first, the global epidemiology, the primary survey, the importance of it, the hard science and the soft science, how we differentiate between the two, hemorrhage control sequences, special scores, which are the mangled extremity severity scores, and the newer advances in the scoring systems, and the management of the vascular trauma-related limb injury. Coming to the global burden, every minute of delay costs us the damage to the tissues. Overall, 30 to 40% of the extremity injuries results because of major trauma. 3 hours is the time limit where the warm ischemia sets in before the nerve injury begins. 6 hours is the golden hour before the irreversible myonecrosis. 15 to 20% of the vascular injuries ends in amputation, which is because of delayed care. The golden principle, the ischemia clock starts at the point of injury. At 0 hour, at the moment of injury, the injury occurs and there is vessel occlusion. By 3 hours, irreversible nerve damage changes are noticed. By 6 hours, the muscle begins to have complete necrosis and thereby limiting the golden hour period. And over 8 hours, irreversible loss and amputation is likely. Revascularization within a period of 6 hours is the strongest predictor for limb salvage. Ischemia clock. So the limb salvage probability is in the y-axis, and the x-axis shows the hours to revascularization. Within 6 hours, 93.5% of the limb salvage rate is noted. And if it is beyond 12 hours, 62.5% limb salvage ratio is noted, which plunges the mobility indexes. Protocol directive should be revascularization is a must, which should be taken care of as soon as possible, ideally within 1 hour of admission. ischemia duration of more than 2.5 hours is the strongest predictor of a compartment syndrome. At the point of first contact, the primary survey should begin. Circulation takes a priority, but we should not forget the A, B, C as devised by the ATLS protocol. First, we should take care of the airway, the breathing, and then comes the circulation of the hemorrhage pattern. D denotes the disability, and E for exposure for further examination. Stop the life-threatening bleeding first. Direct pressure before application of any tourniquet helps us recognition of the injury. Assess the limb only after ABC has been secured. Clinical recognition, the hard signs, where we should operate without any delay. The signs and symptoms are noted as such. The pulsatile or spurting hemorrhages, absent distal pulses, the cold, clammy limb, the rapidly expanding hematoma, palpable thrill or a expandile or a audible bruit, overt signs of distal ischemia. And the action should be immediate operative exploration. There should not be any delay in the imaging sequences. Soft signs, the images has to be done before deciding upon the management course. The history of bleeding at the scene, small non-expanding hematoma, diminished but present pulse, the wound proximity to major vessels, and isolated nerve deficit. We should also take care of the ankle brachial indexes, which if it is less than 0.9, then CT angiography is a must. CT angiography has a sensitivity and a specificity as high as 100%. This table shows the limb salvage rates. If within 6 hours, the limb salvage rate is 93.5%, where the return to work ratio is noted as 58.1%. This goes on and diminishes as we go beyond and try to lose on the time period. Within 6 to 12 hours, the limb salvage rates drops down to 84.8%, and the return to work rate denotes 34.4%. As it goes beyond 12 hours, the limb salvage rate drops down further to 62.5%, and the return to work diminishes much less. We should always consider shunting before fixation. If it is a bony injury is noted, the shunts are temporary intravascular shunts, which reduces the revascularization time from 5.8 to 4.2 hours, and significantly improving the salvage probabilities of the limb. The recent updates, the HUD signs, when it goes soft, the newer evidences. This is the registry data, which is maintained by the American Association of Surgeons for Trauma. This is given as it is in the PROVIT registry, which is a multi-center registry, which is sponsored and maintained by ASST register system. They denoted more than 1910 patients, and they noted 58% presented with a classic heart signs and 42% did not. If the heart signs alone are present, which is now insufficient, hemorrhagic and ischemic signs adds value. CTA is used without any heart signs. Exploration still primary if the heart signs are present. Structured pathways reduces the time to operation room. At the point of first contact, we should identify the hemorrhages and we should sequence it and control it in a sequential manner. First, direct pressure remains the foremost and utmost of importance. Then we should consider the packing of the wound, hemostatic gauzes for junctional sites. We should consider application of tourniquet if it is possible, if the bleeding persists proximally to the wound, and we should consider rapid transportation to definite surgical care. The recent updates, tourniquets, early tourniquet application improves the survival outcomes. Pre-hospital use are linked to better functional outcomes. Level 3 evidences supports an early use of tourniquet. It can mask an ongoing overall active bleeding. Therefore, loosening a tourniquet will identify the bleeding, and if it is present, we should explore it immediately. It can mask, however, an active ongoing bleeding. It can record the time of application on every patient, because application of tourniquet, the time for ischemia, it should be noted further. The diagnostic pathways from suspicion to confirmed injury, any extremity trauma, if there is a hard signs present, we should consider an exploration and further surgical intervention immediately. If not, the ankle brachial index has to be noted, and we can go for an imaging modality like CTA, and we should work it up further. If those identify the bleeding patterns, and we can explore it later on in an OR. However, the imaging modalities must not delay the treatment pattern. Coming to the injury severity indexes, mangled extremity severity score, that is the MES score, which is primarily of importance and has been used in all trauma centers. And if it denotes more than 7, it flags a high amputation risk. If there is ischemia times, which is also if it is considered, and if goes it beyond 12 hours, then the mangled extremity score doubles up. The score more than 12, it indicates a near universal amputation in recent series. It is used as only one input, not as the sole amputation decision. Evolving evidences, beyond MES score, there are newer scoring systems like MU score, which has mangled upper extremity score. And further, we should highlight upon that clinical judgment is of utmost importance, and this should not take into consideration any kind of scoring patterns. If clinically the source, injury pattern is identified and the ischemia is present, and the limb is considered to be extremely mangled, then it should not replace our surgical judgment. We should go for surgery as soon as possible. Life over limb, the damage control sequences. Control the hemorrhage, shunt the vessel if it is possible, stabilize the bone as soon as possible. We should consider the definitive vascular repair later on, and once everything sets in, and if there is a high probability of ischemia, then fasciotomy or a prophylactic fasciotomy is of utmost importance. Orthopedic and a vascular surgery team should work in a sequence for identification of the trauma and its proper management. Vascular adjuncts, the evidences, it highlights the temporary intravascular shunts saves the limbs. It restores the flow before fixation is done, buys oneself some time for bony stabilization. It improves the limb salvage propensity in mangled limbs, aids the neuromuscular and the functional recoveries, standardizes the adjunct in damage control protocol. If shunting is possible, then shunting has to be done first, then fixation of the bone, followed by the vascular repair. Now, the team who is operating, they should identify and they should consider whether the bone has to be fixed first or the vessels to be done first. So, if fixation has to be done first, then it provides a stabilized platform before a vascular repair, protects the vascular anastomosis, and it is preferred when shunts are available to maintain the blood flow. Vessel first, if the shunting is not available, then critical or prolonged ischemia is already present, and then we should consider the vascular repair first and fixation of the bone later on. Preventing the second insult, fasciotomy for protecting the reperfused muscles. If ischemia is lasting over more than 4 to 6 hours, it raises the risk. Early fasciotomy can improve the overall limb functional outcomes. 4 compartment releases are preferred in a leg. Consider prophylactically after long duration of ischemia if it is present, and there should be low threshold in combined injuries. Delayed fasciotomy can lead to established compartment syndrome, which is of devastating sequences. Compartment syndrome, if it sets in, there are 6 P's which can be identified, and these are clinical signs which should be noted. Pain out of proportion and worsening on stretch, paresthesia, early sensory or neurological damages, and numbness, pallor, that is pale, cool, and distal skin, paralysis, that is late or ominous signs, pulselessness, which is present very late, but we should not wait for it, and poikilothermia or the limb temperature drops. Pulselessness is a very late finding, as we have already known, and clinical diagnosis must not wait for it. Supporting measures, as soon as possible, we should administer the antibiotics. IV antibiotics can prevent the long-term infections, and it can also debulk the infection insult. Tranexamic acid and the wound classification has to be done. Antibiotics ideally are preferred within 1 hour of injury. Tranexamic acid early in the bleeding shocks, no added occlusive risk. Grades of wound, the grading has to be done according to the Gustell-Anderson classification and confirm the tetanus prophylaxis status. Tranexamic acid, however, is not linked to higher thrombosis or major vascular repairs in evidence-based recent literatures. The system of care should highlight the pre-hospital hemorrhage control, trauma team rapid activation, the vascular and the orthopedic surgeon should scrub in together, ICU and blood bank has to be there on standby, rehabilitation has to be considered from day one. Protocolized multidisciplinary trauma system shortens the time to revascularization. The take-home messages, time to tissue is of utmost importance, and hence we should act accordingly. Control the hemorrhage before anything else. Hard signs, if it is present, consider operation. Soft signs, we should go for imagings. Revascularization within 6 hours is of ideal scenario. The vascular shunting can be considered early, and this is of importance and it buys oneself some time, and fixation of the bone then should be considered, followed by repair of the vessels. Fasciotomy, earlier it can be considered prophylactically, and we should not wait for it. Orthopedic and vascular surgeon team should plan and consider the case together. Thank you.
Thank you, Dr. Arko Chaudhary. It was a nice and very detailed presentation. I just want to add a few points. The first one is how to transport an amputated part. The most important thing that once a part is amputated, it should be washed in clean water, and then it should be wrapped in moist gauze piece, and that part should be put in a polythene bag, and that polythene bag should be put in ice. The amputated part should not be put directly into the ice. And there are two terms. One is the warm ischemia time, when the amputated part is not put into the ice and is taken to the hospital directly, and the cold ischemia time, when the amputated part is put into the ice, properly preserved, and then taken to the hospital. The cold ischemia time, the time is almost in many times double than that of the warm ischemia time. Means for fingers, the warm ischemia time is 6 hours, the cold ischemia time can be up to 12 hours. So the most important thing is how to preserve and transport the amputated part. Thank you very much, and thank you, Dr. Arko, again.
Hello. Thank you, Chaudhary, for a great representation. You should consider one more thing, that any simple example where bone need to be fixed first, then vessel. Because new fellows should enlighten me.
Thank you so much, Dr. Arko Chaudhary. Please welcome Dr. Donipathi Pradeep, Junior Consultant CTVS at the Mission Hospital, Durgapur, to present on how compound trauma in extremities with vascular injury is managed by CTVS team.
Very good afternoon. Okay. Today I would like to present vascular injury in extremity trauma. The previous speaker already described most of the aspects of vascular injury in extremity trauma. I would like to add a few more things. If we look into the gravity of scenario, the vascular trauma accounts for 4 to 6% in total of trauma admissions. Among them, mostly these alpha males who usually ride the motor vehicles with high speed. They are bulk of the patient load to trauma centers. If we see the mechanisms, most of the times these are roadside accidents. Other than that, civilian assaults and occupational hazard, all these things, they account to vascular injury. And if we see the mechanisms, most of the times if it is penetrating trauma, more likely with sharp objects. Other than that, blunt trauma and with motorcycle accidents. What is the special about vascular trauma? Particularly if it is unprotected anatomical position of vessels, as well as these vessels are located in close proximity to long bones, and the susceptibility of joints to fracture as well as dislocation. And orthopedic colleagues are well aware about the vascular structures in close vicinity to these long bones. So whenever there is a fracture, we need to suspect the possibility of underlying vascular structure injury also. And these hard signs and soft signs already emphasized. If we look into the ischemia time, earlier the age-old saying was 6 hours ischemia time. But if we look into the pathophysiology, particularly the nerves, lack of glycogen stores, they undergo ischemia within 1 hour. So we need to address this part at the earliest. So we need to address this in we need to revascularize the limb within 1 hour. If we look into this graph, within 1 hour, amputation rate is almost 6%. If we wait for further 2 more hours, it inclines to 11.7%. And within 6 hours, it becomes nearly 13%. And with every hour of delay, there is a 10% drop in limb salvage. And so the role of emergency physician in the emergency room is to eliminate the time, try to wheel into the patient into OT within 1 hour, excluding all these logistics and imaging modalities. And primary role is to control the bleed. Most of the times, our bleeds are arrested with direct pressure with gauze pieces. We can use tourniquets also. We try to use the tourniquet as distal as possible, within 5 to 6 centimeters close to the injury. If the bleed is not controlled, we can add another tourniquet just side by the earlier tourniquet. And we need to note down the time also. Almost 2.5 hours we can apply tourniquet. And we come into the management part. It is purely teamwork. Main role is by emergency room physicians, the resuscitation part, and damage control principles and massive transfusion protocols. The vascular injury is no more different from polytrauma. And along with this, the principles of polytrauma ABCD protocol, we need to give more or less similar weightage to circulation. No matter if you take more time to secure beautiful airway by the time patient is exsanguinated. So simultaneously you need to address the circulation part also, as well as along with this airway management. And if we look into the triage, if you encounter a patient of vascular injury in emergency room, you need to assess whether the patient is hemodynamically stable or not. If patient is hemodynamically unstable, straight away wheeling the patient to OT without any delay. Otherwise, if the patient is hemodynamically stable, you need to assess for peripheral pulses, including both non-injured and injured part. If there is no significant injury, you can simply observe the patient. Yes, if at all any injury noted in imaging, you need to plan accordingly. And if we look into the techniques of reconstruction, most of the times primary repair, trimming these injured parts of the vessel, and we can directly anastomose. We can, if we mobilize the fascia a bit, we can repair them with, we can repair primarily. If there is too much distance between two cut ends of the vessel, we can use interposition graft from contralateral, non-injured part of the leg, saphenous vein graft, we can use that also. If that is also not available, we can use a prosthetic graft like PTFE to bypass the segment. And particularly in vascular anastomosis, we need to address this anastomosis blowout. If it is, most of the times we encounter within 5 days of post-surgery, and poorly covered anastomosis and anastomosis done in infected wound bed, these anastomoses are more prone for anastomotic blowout. So we need to cover them with surrounding soft tissues. And regarding amputation, if it is, as described earlier, MES score. This score was developed in 1990s. Nowadays, this MES score overestimates the injury. So, regarding the amputation, it is all about team decision, not about one single subspecialty. Altogether, consider this primary. Try to give a chance, try to take a chance to revascularize the limb as much as possible. If it is not viable, that is the second scenario, we can consider the secondary amputation later. This is the European Society of Vascular Surgery grading in grade 1, 2, 3. If you can see here, grade 1 there is only intimal disruption. In grade 2 there is a contained hemorrhage, and grade 3 there is complete transection. In grade 4 there is occlusion, traction of vessel wall. In grade 1 you can simply observe with antithrombotics, simply with the heparin infusion, and rest of the things you need to address them either surgically or with the help of endovascular techniques. And this is the frequently faced scenario in emergency room. If we encounter a case of lower limb injury, do we need to really revascularize or not? If it is below knee, if any of these, either of the arteries, if ATA is, PTA is intact and there are no signs of an ischemia, you can simply ligate them. The same happens to upper limb also. If either radial artery and ulnar artery, either of them are intact with no evidence of any ischemia, you can simply ligate them. And regarding the venous injuries, if hemodynamically stable, if injuries are at femoral or popliteal veins, repair is preferred over ligation, because if you ligate the major vein, it hampers the venous drainage of the lower limb, that leads to compartment syndrome. And reperfusion injury, this is most of the times we overlook this in emergency room. Compartment syndrome, most of the times it is followed by arterial ischemia, and if the ischemia time is more than 2.5 hours, and classical clinical features. The classical clinical feature of compartment syndrome is pain disproportionate to the injury. And emergency 4 compartment fasciotomy, this is class 1 indication. And if we do fasciotomy within 8 hours post repair, it reduces the amputation risk by 4-fold, as well as 25% decrease in hospital stay. We are all aware about the 4 compartments of lower limb muscles. You need to release all 4. The incision should be just anterior to the this line, fibular head and lateral malleolus. So this incision is for anterior as well as lateral compartments, and this incision is for superficial and deep compartments of the deep posterior compartments. You need to release in this way. This is for anterior and lateral. This is for superficial and deep posterior compartments. And this is for upper limb fasciotomy. In most of the times, we infuse the heparin soon after anastomosis. We run this for 48 hours. We start with 10 units per kg per hour to maintain the ACT between 185 to 200. We can go up to 20 units. Soon after, we bridge the patient with antiplatelets. We advise antiplatelets for at least for 3 months. And this is one case scenario we operated recently. The patient had a civilian assault with a brachial artery injury. Our emergency physicians secured the, arrested the bleeding with the help of a tourniquet here, and the patient was wheeled into the OT. We took the saphenous vein graft from lower limb, and this is the interposition graft with the saphenous vein. The limb was salvaged. This is another one. The patient present to the emergency room. After 12 hours, the limb is severely mangled. This patient underwent amputation. Thank you.
Thank you, Dr. Pradeep, for a very nice and detailed presentation.
Thank you, sir.
Thank you very much. If there is any question from the audience. Okay, thank you.
Thank you.
Thank you so much, Dr. Durgapur Pradeep. Please may I request Dr. Tausif to come on stage to give away the mementos to the doctors here. To Dr. Pradeep. Dr. Orgho Chaudhuri. Dr. Ankit Rai. And last but most senior most, Dr. Krishnendu Goswami. Thank you so much, Dr. Tausif. Next, we have management of hematological emergencies. Early identification matters. Put your hands together for Dr. Abhishek Kumar, consultant hematology, who is going to now present on this topic. Dr. Abhishek Kumar. Can we please have Dr. Debashish Das Adhikari? He's here. Dr. John Acera, to please come on stage to chair the session. Dr. Das Adhikari, can we please have you on stage to chair the session? Thank you.
Good afternoon. Thanks for inviting me for this panel discussion. So this will be an interactive session. So I'll have few questions from our esteemed panelists. And after a wonderful talk on cardiology and orthopedics, I will navigate you all a little about hematology. I'm sure you all must be pretty hungry like me, but so I'll wind up in 10 minutes, I guess. So today's discussion will focus upon main 6 points in hematology. These will be why the speed of hematological emergency, the speed of identification, and the speed of intervention matters. Second, we will discuss about the thrombotic microangiopathies regarding the TTP and the atypical HOS. A pentad, for all the symptoms you could not wait. Even if you have a clinical suspicion on 3 or 4 symptoms, you should start the intervention and the treatment. Third is the DIC. The fourth is the hyperleukocytosis and the tumor lysis syndrome, which we come across in the leukemia, the lymphomas, high-grade lymphomas like the Burkitt's lymphoma, the ALLs. Then is the febrile neutropenia, the neutropenic sepsis, which leads to the septic shock, the golden period of the start of the IV antibiotics. Next is the red flag checklist and some few open panel questions. So why the early identification matters? Early identification matters a lot because the hematological emergencies rarely announce themselves. They won't tell that, yes, I have come and you treat me. You will just face some few vague symptoms like fever, some bruising, and the patient might be encountering a hematological emergencies. So the time is the essence here. It can be as short as 15 minutes to as long as hours, but never as long as days. So it can be as short as 15 minutes where the acute hemolytic blood transfusion reaction needs to be intervened. It can be 60 minutes in a golden period of febrile neutropenia. It can be less than 4.5 hours in the TTP, where plasmapheresis needs to start within 4.5 hours. And it can be hours, not days, in the category of DIC, hyperleukocytosis, and the tumor lysis syndrome. So these are the emergencies we must not miss, particularly for the residents. These are the TTP, the DICs, the hyperleukocytosis, the tumor lysis syndrome, febrile neutropenia, a sickle cell crisis with acute chest syndrome, and acute hemolytic blood transfusion reaction. So a few points about the TTP, thrombotic microangiopathy. So we suspect we have a high index of suspicion if the patient presents to emergency with a severe thrombocytopenia, a microangiopathic hemolytic anemia with some cystocytes on the peripheral smear, some degree of renal impairment, fever, and rarely a neurological sign which can be from the beginning or can be later on in the course of the illness. So act without delay, just send the sample, that is the Adams 13 levels, but don't wait for the results. Start the treatment as soon as possible. Initiate the therapeutic plasma exchange within 4 to 6 hours. An important point here is that you should avoid the platelet transfusion unless there is a life-threatening hemorrhage, which can fuel the further microthrombi formation. And if you are clinically sure that it is a TTP, you have to add caplacizumab or immunosuppression as per the protocol. Coming to a few points about the DIC. So DIC, common triggers are sepsis, the obstetrical emergencies like the amniotic fluid embolism, a malignancy which we encounter like AML, particularly APML, and the massive trauma. So what are the diagnostic clues? The diagnostic clues are the falling platelet count on serial testing, a prolonged PT, APTT, a low serum fibrinogen, a raising D-dimer or the FDPs, and cystocytes on the peripheral smear. So what are the management priorities? So treat the underlying trigger first. What is the cause of the DIC? Suppose it is sepsis, then treat the sepsis with the antibiotics and supportive care. Correct for the bleeding. So DIC can present either with a thrombus phenotype or a bleeding phenotype. So depending upon which phenotype is the main factor, you treat that. If there is a bleeding phenotype, treat with the blood products like the FFP or a cryoprecipitate. If it is basically a thrombus phenotype, basically more thrombi, microthrombi, and less of a bleeding, then we can start with a heparin. But reserve heparin only for the dominant thrombotic phenotype and send the serial coagulation panels. Coming to hyperleukocytosis. Hyperleukocytosis we come across in cancers like AML, ALL, where the WBC count is more than 1 lakh, particularly in ALL and AML. Also, we have to watch for leukostasis in this scenario because whenever the counts is more than 75,000 or 1 lakh, the patient might present with a leukostasis. It can be pulmonary leukostasis leading to dyspnea, hypoxia, a visual change, a confusion, a stroke, like this. So what is the management for this hyperleukocytosis? It is a very, very aggressive emergency. So we have to treat the patient with aggressive IV hydration, avoid red cell transfusion until the counts are falling. We have to start the emergency cytoreduction. Suppose the counts is more than 1 lakh. We can't wait for the counts to come down on its own. So we have to start hydroxyurea, which is an oral chemotherapy. If hydroxyurea is not available, we can also start on cytarabine, which is a very good agent to reduce the counts. And we have seen in cases that on start of cytarabine, the counts can come to normal range within 3 to 4 days. And also, cranial irradiation should be reserved for the refractory CNS leukostasis. So coming to a few points about the tumor lysis syndrome. So tumor lysis syndrome we come across in few cancers, most commonly in Burkitt's lymphoma, a high-grade lymphoma, like a DLBCL. It can also happen in conditions like ALL, AML, and very rarely in multiple myeloma. It never happens in multiple myeloma. So what are the clinical signs and the laboratory signs? So it comes with hyperuricemia, hyperkalemia, hyperphosphatemia, and hypocalcemia with a lot of electrolyte abnormalities. Highest risk is with the bulky tumors. If the size of the tumor is very high, very like more than 7 centimeters, 7.5 centimeter, and some rapidly proliferating tumors, particularly the Burkitt's lymphoma. So Burkitt's lymphoma can present with a spontaneous tumor lysis syndrome. Whether we have not initiated the chemotherapy, but the patient can present with a spontaneous TLS. Even the patient might not be diagnosed. The patient might have a bulky abdominal, suppose the patient has an abdominal pain. We have not diagnosed. On serial imaging, we see that there is an abdominal mass. That can be a Burkitt's lymphoma with a spontaneous tumor lysis syndrome. So what is the management? The management is aggressive IV hydration. We also start rasburicase, but for that we have to look for the G6PD testing. If the G6PD is negative, we can give the rasburicase. Otherwise, allopurinol and febuxostat helps. So rapid IV hydration, allopurinol, and febuxostat is the management of the tumor lysis syndrome. Coming to febrile neutropenia. So febrile neutropenia is a real emergency for the hematology department. So a single temperature spike, only a single fever of more than 38.3 degrees Celsius with an absolute neutrophil count of less than 500 is a real emergency. It's like a ticking time bomb. If we are not intervening within the golden 1 hour, the patient invariably leads to a septic shock, a multi-organ failure, and an ICU admission. So any single temperature spike, we have to look for the CBC. Generally what we do, we look for the total count. But rather than looking at the total count, we have to look for the absolute neutrophil count. What needs to be done once the febrile neutropenia is diagnosed? We have to send the cultures. If the patient has a line, we have to send the paired culture, and don't wait for the results. Start the empirical antibiotic as soon as possible. If you suspect that it can be a GNB sepsis, we should also cover anti-pseudomonal coverage from the beginning. Most probably because we are, in Indian context, we are living in a zoo of bugs and then MDR bugs. So we have seen that if we start with a low spectrum antibiotics, there is no time to escalation and the patient might land into a septic shock. So if we have a high index, clinical index of suspicion, we can start the anti-pseudomonas coverage from the beginning also. Also, we have to assess regarding the severity of the febrile neutropenia. So there are few scoring, like the MSCC scoring. So if the score is low, we have to keep the patient in the ICU or the ward. And then if there are a few signs, like a hemodynamic instability, suspected line infection, we have to rapidly escalate the antibiotics. So hyperleukocytosis, I have already explained, so we'll not go into the details. There are leukostasis, the pulmonary, the neurological, and the other management strategy is the same. Hydrate the patient, prevent the tumor lysis syndrome, hold the red blood cell transfusion, and give the emergency cytoreduction. Cytoreduction can be with hydroxyurea or can be with the cytarabine. Tumor lysis syndrome also we discussed, aggressive hydration, febuxostat, allopurinol. Before, suppose the uric acid is very high, like in the range of 14, 15, so we have to give, consider rasburicase also. So in that case, look for the G6PD deficiency. If the G6PD is adequate, then give the rasburicase. So we have discussed the febrile neutropenia, we'll not go into the details. Few points about sickle cell crisis. So sickle cell, a known case of sickle cell anemia, that patients present with either a vaso-occlusive crisis or acute chest syndrome. So management is basically rapid hydration for the acute chest syndrome, treat any antibiotics, give any antibiotics covering the typical coverage, also give the supplemental oxygen. And from the sickle acute chest syndrome, we have to also give the exchange transfusion or a simple transfusion. Few points about acute hemolytic blood transfusion reactions. So recognize the symptoms early. If the patient has a fever and chills, It can be a febrile non-hemolytic transfusion reaction also, or it can also be a ABO incompatible blood transfusion reaction also. So if it is an ABO incompatible acute hemolytic blood transfusion reaction, recognize as early as 15 minutes. If the patient has a fever, chills, the warning sign is hypotension and tachycardia. If there is hypotension and tachycardia, then just stop. Anyhow, you have to stop the unit blood transfusion, then send the samples to the laboratory, send the blood sample also, and the donor sample also, and the patient sample also. So some red flags when to stop and escalate. If there is a hyperleukocytosis, if the counts is more than 1 lakh with the features of leukostasis, we have to give emergency cytoreduction for these patients. If there is a fever with NC less than 500, we have to give the empirical antibiotics. So now a few questions to our esteemed panelists. So the first question is, in a resource limited settings, without the facility for the Adams 13 testing, so how do you decide whether to start, how to start the plasma exchange on the clinical suspicion alone? So do you wait for the reports or you start the plasmapheresis on the clinical suspicion?
So I think that this is a really difficult question. This is something I often defer to my hematologist colleagues. So I'm fortunate enough to work in a center where we have hematologists on call for us. So I think a lot of the take-home messages for me as an emergency physician are to recognize the patterns of possible TTP or any of these other hematologic emergencies and engage my hematology colleagues early on in the case discussion and let them weigh in and help us decide if we should be treating these cases or not. Because I'm not sure that I'm the best qualified person to make that decision.
I think that as emergency physicians, and I agree that here is a gathering of emergency doctors. One thing is that these children with any hematological conditions, even also they have a vitals normal, stable, they should be given priority 1. And they should be addressed within 8 minutes with a normal vitals, because as you perfectly said, they are all tip of the icebergs. And most of the time, investigation is not the choice. And early intervention is the choice, and it will start with A, B, C, D, E. Like example, a sickle child, and you just miss the antibiotics within first 1 hour.
Yeah.
It can go into chest syndrome, and 80% of the children will die after that. So, yes, it's all hematological patients with a stable, normal vitals. Still, it has to be given priority 1, has to be seen in 8 minutes. And any blood products, you have to discuss with hematologist, because you might be thinking that blood products will be life-saving. Actually, that blood products can kill the life also. And second thing is, all blood products when you are using, never forget the anaphylaxis, because any blood products can cause anaphylaxis. And as an emergency physician, you miss the anaphylaxis, patient will die of anaphylaxis, not the hematological problem. So hematological intervention will always give it to the hematologist's hand, because you need to study 3 more years of DM hematology to answer. But as an emergency physician, ABCD is in our hand, and that is the priority for the patient, not the hematological underlying the disease.
Yeah, so that's why the emergency physician and the hematologist should communicate more frequently in these cases, and then they have to be on the same page regarding the treatment. So my next question is regarding DIC. You all must be seeing a lot of DIC, but how do you draw a thin line between treating with heparins anticoagulation versus supporting with the blood products? Because it can have, it is like a seesaw, which to balance, how to balance it. This is a real tricky question. So how do you treat these patients? Like suppose you have done the PT, APTT, everything is prolonged.
Even also for the DIC, sir, you have to depends on the investigations. But clinically, you won't be able to diagnose DIC in emergency department, and DIC patients are very unstable. And by default, within 30 minutes, they have to go to PICU or MICU. And there, after stabilizing, when the report comes, then only the blood pressure has to be, products has to be decided. Blindly, you should not give it.
Yeah. Next question, what is your institutional protocol, both for CMC and for yours, for febrile neutropenia? And the neutrophil count is very low. how do you start? Definitely in US, the drug resistance might not be a problem. For Indian scenario, we'll have to take both of your opinions. So what is your institutional protocol for that? You start with a very low antibiotics, low spectrum, or what?
Yeah, I mean, in our institution, when we're dealing with febrile neutropenia, we usually use a broad spectrum antibiotics that cover Pseudomonas. Usually cefepime is the first line treatment that we use. I do know that some cancer centers, like I've seen the protocols at MD Anderson Cancer Center in Houston, Texas, they have outpatient protocols for management of febrile neutropenia. However, the criteria for falling into that pathway are very narrow. You have to live within a certain radius of the hospital. You have to be a very reliable patient. You have to be able to check in with that patient on a regular basis. They usually use oral fluoroquinolones for those patients that are being treated on the outpatient center. We don't use that so much in our facility. We usually use, we usually admit all of these patients and give them IV antibiotics, usually with cefepime or some other third or fourth generation cephalosporin.
Actually, very difficult questions because your pathogen's resistance pattern depends on your local way of treating antibiotics. The resistant pattern of CMC Vellore may be different in Durgapur.
The antibiogram may be different.
Yes. So what happened like 3 years back, we used to start, if there is no high risk, we used to start cefotaxime or ceftriaxone, but it's all resistant now.
All resistant.
Then we gone to piptaz and amikacin. Then we found that also resistant. Nowadays we gone from Merovanco, that we don't know how long that will last. So it's all the way antibiotics used in your local areas and what is the resistant pattern developed in the community and what's the microbiological or infectious disease recommendation for you. So there is no uniform path you can make it. Right. You have to be communicate and get the local pathogen and resistant patterns, and you have to make your own protocol.
Yeah. So the institute protocol matters a lot in this case. When I was in Tata Medical Center, our policy in febrile neutropenia, after studying the antibiogram pattern, we started with piptaz and amikacin from the very beginning and then escalate depending upon the hemodynamic stability or infection or worsening of the patient to meropenem and polymyxin B.
Definitely not cefotaxime or ceftriaxone. It's gone. It's too late.
Yeah. Okay, that's all. Thanks a lot for the wonderful discussion.
Thank you, sir.
Thank you so much, Dr. Abhishek Kumar, for enlightening us. I would request Dr. John Asevra to please give away the memento to Dr. Abhishek Kumar. Joined by Dr. Das Adhikari. Thank you so much, sir. Thank you, Dr. Debashish. Thank you, Dr. Abhishek. I would request Dr. Asera to please stay back on stage for the valedictory session. Now it's time to reward and recognize the pass-outs of this year's MEM course. Can we please have Dr. Parthopal, Medical Director, to join Dr. Asera on stage, along with Dr. Tirtho Mukherjee. Dr. Tirtho. Dr. Tirtho, আমার টাইম নেই তাড়াতাড়ি কি দেখছো এখানে
Hello. Yes. Dr. Arnab Mondal. A memento from ourselves. Dr. Parul Agurwal. And a second, this thing for Parul as a chief resident. Parul, once again, your chief resident. As a chief resident. Dr. Pankaj Kumar. Thank you. Thank you, Pankaj. I would request Dr. Keshav, he has already passed out and received his certificate, to please come and take his memento. I would request all the three, this memento. I would request all the three MEM residents passed out, please come on the stage for a picture session. Dr. Sunita and Dr. Shomitra, Dr. Tausif sir, and Dr. Devashish sir, please come on the stage. आप आइए. Rashid sir है क्या? Dr. Rashid, oh हाँ, please. Tarokda, come. और इतना को दे.
Thank you so much, everyone. I'm sure these learning sessions must have used up all your energy, and it's time to recoup. Let's break for lunch and join back for the next session in about 30 minutes. Thank you.